My name is Bill Galley. I'm the director of the O'Brien Institute for Public Health, and it's my pleasure to welcome you all and to kick off today's Gairdner Symposium. The theme of today's symposium is Big Data for Health, Expectation, Opportunity, and Impact. And the Cummings School of Medicine has had the honor of hosting a series of Gairdner Symposia over the years. We will hear a little bit more about the Gairdner Foundation and the symposia that are staged across the country. Here at the University of Calgary and in the Cummings School of Medicine, we have had an alternating opportunity and honor for our 7 health research institutes to host the Gairdner Symposia. And so this year, the O'Brien Institute for Public Health is hosting with our theme of Big Data for Health. I want to begin by acknowledging that we are on the lands of Treaty 7 First Nations here in Calgary. Calgary is also home to the Métis Nation of Alberta, and not at all making light the land acknowledgement being just made. I also do need to say that we're at the Red and White Club, and behind us have the football field of the Grey Cup champion Calgary Stampeders, who just won on Sunday. So yes, everybody should cheer about that. So we were kicked out of the theaters at the Health Sciences Center because there are medical school classes happening in the big theaters, so we needed a big venue, and it's not so bad here being at the Red and White Club. So in the day today, we will be showcasing a number of outstanding visiting lecturers. We have 3 that we'll be introducing, but I will briefly mention we have Alan Lopez, who is a Gairdner Award winner. We'll be introducing him shortly. Gina, Neff from Oxford, Eyal Oren from Google. We're very excited about their plenary lectures. And then we have a showcase of local faculty who are doing fascinating work in the domain of data science, big data, and we will be sharing some of that work. And I think this way you'll get a nice mix of external expertise and local energy and talent in the work that's being done, and we're really excited. Without further ado, I'm just going to turn things over to my colleague, Cello Tonelli. Cello is the Senior Associate Dean Research for Clinical Research in the Cummings School of Medicine, and I'll let him say a few words.
Thanks very much, Bill. I'm Cello Tonelli. I am the Senior Associate Dean of Health Research at the Cummings School of Medicine, and it's my great pleasure to welcome all of you to this Gairdner Foundation International Symposium on Big Data for Health. We're really fortunate to have the Gairdner Foundation support. As you know, they recognize leading medical researchers from around the world, and our university has had a strong partnership with the foundation for many years. Receiving an award from the Gairdner Foundation is extraordinarily prestigious. As of today, 86 recipients of Gairdner Awards have gone on to win a Nobel Prize. Today is the 4th time in recent years that the Cummings School will host a Gairdner International Symposium. International symposia bring together a past Gairdner laureate and several other internationally recognized researchers to speak on an important scientific theme. We're really proud of this opportunity to host a symposium like this, and we're very grateful to the Foundation and to the Government of Alberta for making this event possible. As all of you know, our medical school is committed to achieving the eyes high goal of excellence in research and in scholarship. And every scientist knows how important it is to have outstanding data for doing research that matters. So our school, over the last few years, we have made major investments in the people, platforms, and partnerships that will allow us to capitalize on the ever-increasing quantities of rich health data that are available to tackle important health issues. For example, with support from the provost, our school has hired 25 leading scholars that work in data-intensive disciplines related to precision medicine and precision public health. And we've invested nearly $4 million to establish the Center for Health Informatics, which will open shortly on the 5th floor of the TRW building. Of course, we continue to capitalize on our strong partnerships with Alberta Health, Alberta Health Services, and Alberta Innovates to acquire, link, and analyze the outstanding data that we have here in the province so that we can continue to improve clinical care for the benefit of all Canadians. Given all of this, it's especially fitting that this year's Gairdner International Symposium will tackle the opportunities and challenges that are associated with big health data. We have a really outstanding group of diverse, scientifically talented speakers this morning, including some of our own leading researchers from here at the university. And I know that we're all looking forward to what they have to say. So without further ado, I will now invite my colleague, Dr. Nnamdi Beret, a terrific scientist himself, to the podium. Dr. Beret.
Good morning, everybody. My turn to welcome you to Calgary, for those of you who are not from Calgary, and to the university and to this site. It's a real pleasure to be here. My name is Nnamdi Beret, and I'm Associate Vice President Research for the university. It's always an honor to have the Gairdner Foundation on our campus, of course. And as you know, the Gairdner Foundation recognizes the world's most creative and accomplished biomedical scientists. Here at the university, we are regularly inspired and actually, as far as I'm speaking, humbled by the Gairdner Foundation and the remarkable scholars they connect us with. We are on a mission nowadays to find answers to very complex, ever-changing global health challenges. And I'm very proud that our O'Brien Institute is a World Health Organization collaborating center, which elevates our ability to ensure the work we do is informed by and has meaningful impact on our global community. It's impossible to affect change in a silo. So collaborations that reach across disciplinary boundaries are absolutely vital. There are answers within the incredible volumes of existing data, but we must leverage our collective expertise to understand, analyze, and protect that data in order to actually deliver solutions for our communities. Information and data protection through cybersecurity and privacy is a critical field of study today, as both interests and threats in this area do increase. We're working very hard at the university to lead in these areas. The UCBC brings our biostatisticians together from across campus to play a key role within biomedical research. They're addressing complex data structure problems in very different areas, multidisciplinary, such as genetics, genomics, neuroimaging, epidemiology, population ecology, and others. And they're training the next generation of experts, the demand for whom will only continue to grow. In this context, the University of Calgary is fortunate to have capacity and expertise from scholars at the Multidisciplinary Institute for Security, Privacy, and Information Assurance. Looking beyond the walls of our institution, together, we possess immense capacity and expertise. And conferences like this deepen our relationships and foster new collaborations. This helps bridge the gap between research and practice. The experts you'll hear from today have made tremendous contributions to their fields and had a huge impact on advancing science for the benefits of human health. You will hear from Professor Alan Lopez from Melbourne University. He's a transformative research leader who is behind the global burden of disease study. You will also hear from Professor Gina Neff, Oxford University, and Isle Owen from Google AI, both leaders in the field of big data management and artificial intelligence. So with this, thank you very much. We really look forward to this day, and it's a pleasure to welcome you once again.
Are you getting tired of opening speeches? I just want to introduce Janet Ressant, Dr. Janet Ressant, who is the president of the Gairdner Foundation and a Gairdner winner herself in 2015, so one of Canada's leading scientists. We're very proud of the work that she does. I had the privilege yesterday of being invited to a luncheon hosted by Anne McCaig, where the Gairdner Foundation was welcomed to Calgary, and I learned a fair bit more about the foundation than I knew, and the tremendous stewardship for science internationally that the foundation does, and then the sharing of science in symposia like today. So going on, I just want to say it's a remarkable asset that we have, a foundation that we are to be very proud of. And Dr. Rassant, I'll invite you to the podium to say some welcoming words.
So I do promise this is the last talk before you get to hear the guest of honor, Alan Lopez. So thanks, Bill, for your kind introduction. And really, it's a pleasure for the Gairdner Foundation to be here today, sharing with you this great occasion. It's amazing to see such a great audience here for this event. So I'm not going to say much about the Gairdner Foundation because you've heard quite a bit already, but it has been going in Canada since 1957, founded by a philanthropist in Toronto who wanted to recognize research that's had an impact on health. And that was a simple thing, internationally, and really the very best. And so over those years, we've given out over 380 awards for international research that had an impact on human health. And actually 89 have gone on to the Nobel Prize. You're out of date. And in fact, two in the last round of Nobel Prizes were previous Gairdner awardees. So that's one of the measures you can use to say this is one of the world's most prestigious awards. The Global Health Award, which Dr. Lopez shared with his colleague Dr. Christopher Murray this year, is a new award on the block. It's only been going for about 10 years, and it's specifically for scientists whose research has had an impact around the globe, really looking at global health issues. And if you think about the global burden of disease study, it's a perfect example of something that has gone beyond the borders of Australia, the US, Canada, to be a measure of the impact of the global burden of disease in every country, and something that can be used as the base on which countries can set health priorities and really see how disease burden and health burden is changing over time. And you're going to hear much more from Alan about that. So we give out prizes. We're celebrating excellence, but that's not enough. We want to leverage that to convene leaders, and that's what we're doing today, convening leaders, bringing our awardees to Canada, sending them across the country, which we do during Gairdner Week in October, visiting different universities, and also taking part in these kind of more focused symposia with our partners across the country. And we see that as a way of building new collaborations, building new ways of bringing expertise from around the world to interact and move our science forward in Canada. So number one, celebrate excellence. Number two, convening leaders. Number three, inspiring the next generation, perhaps the most important thing we do. And so as part of the Gairdner mission, we really want to reach out to students at universities, but particularly to high school students. And our laureates, when they go across the country, also attend high school sessions where they interact with high school students and talk about their careers and what it's like to be doing science, and trying to encourage people about the importance of taking training in science, whether you're going to be a researcher or not, the importance of having a scientific background as we move into an era of intense technology and rapid transformative change, as we're going to hear today. So that's what we do, and it's my job as president is great. I'm having a lot of fun. How could you not enjoy celebrating science and meeting such great people? So among the great people I've met is Dr. Alan Lopez. This year, they were awarded the John Dirks Canada Gairdner Global Health Award. They shared it for their groundbreaking work in conceptualizing and quantifying the global burden of disease. The first global burden of disease study was published in 1996, and it's now grown to be a huge enterprise, as you'll hear, that covers more than 300 diseases, injuries, health impacts across 200 different countries, and records the impact by age, sex, from 1990 to the present. So you have this longitudinal study and information to look at trends, and really this has influenced global health policy around the world. So Dr. Lopez holds the position of the Melbourne Laureate Professor and the Rowden White Chair of Global Health and Burden of Disease Measurement at the University of Melbourne, but he also travels around the world and has other positions in his travels. He is Director of the Global Burden of Disease Group in Melbourne. He's also a visiting professor and director of the IHME Big Data Institute at Oxford University and an affiliate professor of global health at the University of Washington, where his partner, Dr. Chris Murray, works. So he's a world traveler and a global health researcher par excellence. So without further ado, please join me in welcoming Dr. Lopez to the stage.
Thank you very much, Janet, for that introduction, and also to Bill and Andre and leaders of the University of Calgary for the very warm welcome that you've given to me in a very cold climate. Coming from Melbourne, it's a little different to ours, but thank you very much. So as Janet mentioned, Professor Christopher Murray and I have been working on the Global Burden of Disease study for over 3 decades, and that is what our award has been recognised for that work. And what I'd like to do this morning is talk a little bit about that study, but I want to do it in the context of the theme for the seminar. I'll get to it in a moment, which is big data. And so just before we launch into the Global Burden of Disease study, and I'll talk a little bit about in a moment how I want to approach that in the next 45 minutes, just a common sense understanding among all of us of what big data is. At least I'd like to give you my definition, and then we'll see how that fits with yours, because we should keep this in mind as we go through the GBD study in a moment. So big data, first and foremost, is not just lots of data, although that's what the burden of disease study is. But we define it, at least I do, by 3 V's: volume, velocity, and variety. Obviously a lot of data, volume. Variety of data, meaning we're pulling information from different sources in order to solve common challenges or particular issues that need to be addressed. And velocity, meaning it's coming in pretty quickly. It's not just something you do once every 10 years, but you've got volumes of data from different sources coming in very quickly in order to address this particular scientific challenge, which in our case is the global burden of disease. So I'll just put that up there to keep that in mind as we go through the GBD study. Just write this a little bit higher up for me. So what I want to do this morning is talk about 4 aspects of the global burden of disease study. I'll start by giving a little bit of background. I know some of you in this audience are painfully aware of the burden of disease study because you work with us on it, and you know how difficult that is. So some of you know it, but many of you may not. And so I'd like to just talk a little bit about the origins and the history and the thinking behind the GBD study. Then I'd like to talk a little bit about the results. What are some of the higher order results that we see coming out of the successive GBD studies, particularly in the most recent years? So in other words, global health transitions. We're all citizens of the planet. We're not just citizens of Canada or Australia. What does this mean for global health? And then talk a little bit about how the GBD has morphed from essentially a massive exercise in global descriptive epidemiology and health accounting into a platform which can and is being used to provide critical input into major global public health dialogue today, whether it's HIV, obesity, tobacco, sustainable development goals. There is a role for the GBD in much of this, and I'll explain that with some examples. And then finally, some implications of the GBD for health policy and practice. I think it's important we take a step back at the end of this and see what I think at least it all means for global public policy. Janet has mentioned that it's now widely used and referred to in public policy debates, be those in WHO or the World Bank or indeed increasingly in 195 countries. But there are some common messages there for health policy and practice that I would like to illustrate. And I apologise in advance. We're seeing 2 screens. I, typical as an epidemiologist, try and cram a lot of things on the screens, and so you won't be able to see it at the back. But it has just been published, all of it in The Lancet here in 450 pages, so you are able to read it in a bit more detail. But firstly, what is the Global Burden of Disease Study? What's the operational definition of this study that we're being acknowledged for? We like to think of it as a systematic scientific effort to measure health loss from as many diseases and injuries and risk factors as is likely to be of importance for public health dialogue anywhere, and to do that by granular detail, by age, by sex, by location, i.e. country and time. We do it now in the GBD for 195 countries and territories, not just Canada, not just Australia, United States or Zimbabwe, 195 countries and territories for each year from 1990 to the present, 2017. And increasingly we're doing subnational assessments of disease burden for large populations. So, for example, what does it mean to have a disease burden estimate for China? We really need to break that down into, as we do into the provinces of China or the states of India, Iran, Indonesia, large populations we are breaking down now into subnational assessments, and that's in an increasing trend. It is currently, as far as we've been told, the largest current publication effort on the scientific publication effort on the planet. It involves 3,641 collaborators as of May this year, when the final results went into the Lancet. So it is a very large collaboration, and I'll talk more about that in a moment. And it's not just from the rich countries. We have collaborators from virtually all countries, 143 in fact. We don't just do one or two of our favourite diseases and injuries. We try to quantify disease burden from almost 360 diseases and injuries. So to be truly useful for public policy, you really need to be able to compare health loss from as many conditions as ministers of health or senior policy people are likely to want to compare for different reasons in countries, and so you need to measure it. And that's what we try to do in the disease burden, in the burden of disease. And as I'll explain in a moment, we don't just talk about premature mortality from various diseases. We talk about non-fatal sequelae of diseases and injuries. In other words, things that don't kill you, but nonetheless cause a lot of health loss in populations. This is based on the premise that health systems everywhere spend an awful lot of resources not just on keeping people alive, but on keeping people healthy. So each round of the burden of disease is approximately 38 billion estimates. So this is my definition of big data, or at least the volume part of it. So each time we do this, we produce 38 billion estimates, and each of those estimates has uncertainty, because we think it's very important that the public policy community understand how much we don't know just as much as how much we think we do know. And this has implications, as I'll show later, for health information systems. It's updated annually. It's done each year, so it's a massive amount of work each year. The latest edition was the one in the Lancet, which was published just 2 weeks ago, an entire issue of the Lancet of 450 pages, so there's some light reading for you there. But it's also published in major journals and policy reports, and increasingly, we found a lot of people use the data visualizations, which are available on a web address I'll show you in a moment, but it allows you to play with the data in a much more dynamic way. So that is what it is, but why do we do it? Why was the Global Burden of Disease study conceived in the first place? And the idea is that the essential health intelligence underlying health policy debates anywhere ought to be based on a common sense understanding and a comparative understanding of the leading causes of health loss in that population. It's not the only input, obviously, but it's very hard to imagine having a rational debate about health sector priorities without some understanding of the leading causes of health loss in a population. And the fundamental premise behind doing the burden of disease is that policy ought to be informed by valid, by reliable, and timely data, and that if it's not the case, then poor quality data, which is often what we see in populations, poor quality data generally will lead to poor decisions, health decisions, leading to lost opportunities to improve population health. And we'll see the consequences of that in some of the slides. So in summary, some of the key principles of the Global Burden of Disease study: it's massive. In other words, it's very comprehensive. It tries to quantify a vast number of diseases and injuries over time. It's based on the assumption that informed estimates are always going to be more useful, as long as they're transparent, than no estimates. Ministers very often will say, well, we don't have any estimates of rheumatoid arthritis or depression, so if we don't have an estimate, it can't be a problem, I don't have to deal with it. And that is absolutely wrong. And so what the burden of disease study tries to do is to make those estimates using some of the methods that I'll show in a moment in order to inform public policy. And that finally, the comparability of estimates is critical. It is extremely important that the users of the GBD data have confidence that they are comparing like with like. When they're looking at health loss from TB and health loss from road traffic accidents and health loss from tobacco, they're comparing the same entity and the same quantity in a way that can be useful for policy. So this is the current map of those 3,641 collaborators. It's probably grown quite a bit since then. But it shows you the vast outreach of the global burden of disease, global collaboration. The darker countries there are countries where we have more than 100 collaborators working with us. In the United States, Canada, not quite 100, somewhere between 50 and 100, as I said, some in this room. China also, but places like Australia, India, Iran, Ethiopia, Brazil, and the United States having a significant number of collaborators. But virtually throughout the world, with relatively few exceptions, we are working with people on the global burden of disease study. These are some of the publications, the GBD 2015 on the left, GBD 2016 on the right, and then GBD 2017 just published. When I say 17, that means it's estimates for the calendar year 2017, published in 2018. So you can look those up in the Lancet. Each of those are about 400 pages and have about 7 or 8 basic papers reporting on the same estimates each year. So the rationale behind the GBD study I've explained, but I want to go back now because some of you may not be aware of how this all started. Hopefully now you understand why we do it, but what was the situation when we first did the burden of disease study in 1990, when Chris Murray and I began this? And I think some of the bullets there explain it pretty well, particularly this second one there, that at the time in 1990, when I was at WHO, and I went around to the disease control programs and asked them, how many child deaths are due to your condition, pneumonia or TB or malaria, diarrhea? And when I added up those number of child deaths, I was killing children 3 times over. And so that's just a reflection that advocates are not good epidemiologists, that they mean well, but at the margin they're going to be inclusive rather than exclusive. And so what the burden of disease study tried to do was to bring some order to those to the information that the advocates had, in order that we had something that was more believable in terms of a global picture of mortality and disability. And at the same time, when we did the first burden of disease study, there was a huge volume of epidemiological information, lots of research studies, but they were very difficult to compare because they had different methods in different populations measuring different entities of interest to health. So it was an extremely confused and complex picture, and from which it was very difficult to determine the most important health problems and how they were changing. So that was the origins or the basis when we did the first burden of disease study. It was done at the request of the World Bank, and the World Bank each year used to issue an annual report called the World Development Report. And for the first time ever, in 1993, the World Development Report was on health, and interestingly, the title there, it's the one up the top in red, Investing in Health. It was the first time that the World Bank took health as a development issue seriously. And what the bank wanted to do was to develop cost-effective packages of interventions against the main causes of health loss in different regions of the world, depending on what was the main causes of health loss in those regions. And so it needed to have an estimate of the burden of disease. I was at WHO at that time. Chris Murray was at Harvard doing his medical studies, and we were approached by the World Bank to do that study. So the preliminary results of the first burden of disease for the calendar year 1990 were published in the World Development Report. That immediately got a vast outcry from the global scientific community saying, how did you do it? What are your methods? Let it show us more information. So Murray and I published 2 large books down there in green and purple on the global burden of disease and our results of global health statistics. We prepared the results for the 8 World Bank regions, 107 diseases and injuries, not the 359 that we work with now, but nonetheless much more than was present at before this study. We did 10 risk factors as well. quantified those. And we only produced estimates for 1 year, 1990, but we made projections, interestingly, to 2020, which, as I'll show in a moment, have been superseded only recently. And those projections have been used and cited widely, showing the tremendous appetite in public policy for using information about what the future might look like, because it's something we can change. So Chris Murray and I were the two people who did the study, the first global burden disease study, with a small team of research assistants at Harvard who we didn't pay any money to because we didn't have any. And this is what the global burden disease headquarters looked like. This is Chris's barn in Maine, and all I remember about that was it was 10 feet of snow every time I came there. And the guy with the shovel, you see who's doing all the work, that's me. And the one standing back there walking the dog and relaxing is Chris. And that's our headquarters there. This frozen barn in Maine is where the study was done. I'd fly over from Geneva and spend 2 to 3 weeks at a time, and we would just work insane hours. We would start at sort of 6 in the morning, go till 6 at night, have an hour for dinner, and then start again at 7, go to midnight, get up the next day and do the same thing. And the only time we took off was every Sunday afternoon, where we drive up to one of these shopping outlets near the Canadian border. And I don't like shopping, and neither does Chris, but at least it was a change from shoveling snow. So things have moved on since then, and that was the initial GBD study. It's got much more complicated. In 1990, just to give you some idea, there were 9,360 condition, that is disease or injury, age, sex, location, year estimates, 9,360. In the GBD 2016, I haven't calculated for 17, that number had risen to 401 million. To show you the vast increase in granularity that the public community have asked us to develop on global burden of disease. So the diseases and injuries have gone from 107 to 359. The sexes obviously remain the same at 2. But the number of disabling sequelae of these diseases and injuries has gone from 483 to 2,982, and so on. You can see that the vast number of increase in the granularity of the study, and this just reflects public policy demand. That it's not enough to have all of Africa. You need to have it broken down by country, by year, and so on. Now, our approach to estimation, I promised I wouldn't show any algebra, so I won't, but what we essentially try to do is develop models to estimate those 401 million estimates where we don't have data. You might ask, well, how do you estimate lung cancer in Mali? That's a good question, because there isn't any data on lung cancer in Mali. But it doesn't mean people aren't dying of lung cancer or ill from lung cancer in Mali, and we need to estimate that, and we do that using covariates. And we have various models, a cause of death ensemble model called CODEM, which we've developed, which is essentially a way of modeling disease outcomes as a function of covariates. So lung cancer, if you know something about tobacco and a few other things, you can get a reasonably plausible estimate if the model works okay. And we spent a fair bit of time working on models. We have another one called DISMOD, which is our way of constraining epidemiological consistency between incidence, prevalence, remission, case fatality, and mortality. There needs to be a common sense and consistent relationship between all of those variables. We do that by forcing everything through DISMOD. And then when we get disparate sources of data, which is often the case, even in a country like Canada, we need to make sense out of disparate sources of data, often disagreeing with each other, and we do that using a statistical tool called Gaussian process regression. We generate uncertainty around everything we do, because in my view, and Chris's as well, it is really important that policymakers see how poor some of the estimates are for their population, yet how important they are for policy and how little they know. And so what we're trying to do is to use that information to drive a dialogue to improve health information systems everywhere. And we try to, for every model we create, we validate the model using a cross-validation design where we hold out some of the data and then use the model to try and predict that. And also for every piece of data that we have in the GBD, we don't just assume it's correct. Everything is screened through a data audit, for example, on cause of death information, even in this country. Some of your physicians are lazy, like in my country, and they code an underlying cause of death to senility, ill-defined causes, heart failure, or something vague like that. And we need to reallocate those to what we think are the true causes of death. What we measure in the burden of disease, the output that I'm going to show some results for in a moment, well, we do the traditional metrics of incidence, prevalence, mortality by specific conditions. But in order for us to meet the challenge in the burden of disease of simultaneously uniting morbidity, disability, and mortality in a population, we've used this metric called DALYs, or Disability Adjusted Life Years. And it consists of streaming out into the future the amount of health loss in a population that arises from events that occur today. And we do that in two ways. We measure out premature mortality by taking deaths by age. So we weight deaths by age by the amount of years of life lost by dying at various ages. So a death at age 5 will be much more important in the calculation than a death at age 95. And then we also measure years of life lived with disability because, as I mentioned earlier, public policy is concerned, health systems are concerned about, or should be, about disability in their population. So we take the prevalence of disability by age and sex and location, and we weight that on a disability scale of 0 to 1. So various forms of disability will cause more health loss than other forms of disability. We add the two together, YLLs and YLDs, and that is the metric of DALYs that we use for the burden of disease. Now, believe it or not, this is a simplified version of the global burden of disease study. Somewhere in the middle there is a box which says DALYs from diseases and injuries, and another box that says DALYs from risk factors. And we calculate DALYs from risk factors separately because public policy can intervene against risk factors. It's not enough just to show the amount of health loss in a population from ischemic heart disease or road traffic accidents or lung cancer. We need to show policymakers how much of that is due to tobacco or alcohol or drug use or unsafe sex or occupation or whatever the risk factor is that public policy can intervene against. And so somewhere in there is those final targets. But on the left-hand side is a whole, I'm not sure what the colour looks like to you, but on my screen it's orange or pink. All of this is just the amount of work to do to get mortality, to estimate the volume of deaths by age and sex in Zimbabwe or Canada or elsewhere. Over on the right-hand side is the whole series of boxes of work that are related to estimating the causes of death for those deaths. And each one of those boxes breaks down into a series of subsets and sub-steps that I have not shown. Over here is the amount of work that goes on to estimate non-fatal disease, particularly for things like depression or low back pain or low neck pain. Not major causes of death, if at all, but major causes of disability. How do we assess them to calculate DALYs? And over here on the left-hand side is all the work on risk factors, where we estimate the distribution of risk factors for 84 risk factors in populations by age and sex and time. So each one of those has a subset of steps, and they all lead to those blue boxes in the middle, which are YLLs and YLDs from diseases, injuries, and risk factors. And to give you an idea of what all that means in terms of data, this shows for GBD 2017. I'm sorry, it's a little off the scale there, but just the various data sources that we're using in the GBD study. And when I say we, it's no longer Murray and Lopez, it's 3,691 collaborators working very hard around the world. But the number of household surveys we use to estimate from 1990 to 2017 was about 6,000 individual record household surveys that were used for various aspects, including 545 new household surveys that were used just for GBD 2017. We have data on incidence, prevalence and case fatality extracted from systematic reviews for over 15,000 systematic reviews, including 4,500 in the last year alone. Vital statistics data on who dies of what in populations. We have about 3,356 country years, including 155 in the last year alone. Canada deaths in 2016 would be one of those points. So it shows you how many, and indeed when you sum up all the deaths, we look at death certificates for over 650 million people who've died since 1990. And then you can see some of the other data sources. It's just a massive amount of information that we're using in the GBD. We also use covariates. As I mentioned, we often don't have data on key entities of interest, and so we need to estimate them. We do that using covariates, and we have 581 time series by country, by year, from 1980 to 2016, based on commonly available data from surveys or censuses or other data sources such as the Food and Agriculture Organization have food balance sheets from which we can estimate a lot of the dietary covariates, or tobacco sales data, or motor vehicle ownership information. And those variables are absolutely critical in the GBD exercise because they go into the cause of death prediction model, CODEM, in order to predict causes of death where we don't have any other information. And you can look at these data sets if you have time. This is the website, the it's called GBD or GHDX Global Health Data Exchange. It's hosted on the IHME website, and it has metadata on more than 100,000 GBD data sources. So if you want to know, well, how did you use the survey on health in Canada, the latest available one, whenever that was, go and have a look, and we'll show you there what's the data and how we've used it, what was the metadata describing that particular data source. So enough on the background. I hope I've convinced you I'm in the right seminar about big data. But what I want to do now is just go and show what does all that big data mean for if you're a public policy specialist, if you're the Minister of Health of a country, or you're the Director General of the World Health Organization and you're responsible for improving global health, what are some of the big global health transitions that come out of it? In this graph, I've just summarized deaths. The number of deaths that we estimate that have occurred each year on the left-hand, on the x-axis down here, from 1950 through to 2017. And you can't read any of this, but the red there are child deaths. These are deaths below at the age of 5, and as you get higher up, these are neonatal deaths, deaths of infant under 1 year, and deaths of children. And then as we go up, you get young adults, and right at the very end, in dark blue, you have deaths of the elderly at age groups 95 and over. And you can see in recent years, the blue is getting bigger, meaning we're getting more and more global deaths in the elderly. We're getting fewer and fewer global deaths in children. And that shrinking of the red is one of the biggest public health successes of our lifetime that we should celebrate more. A huge reduction from 20 million annual child deaths down to about 5 million today. Now, that's still 5 million too many, but it does reflect the success of public health programs. You're wondering what the big spike here is, 1958-59? That's the Chinese famine, showing you the impact that that had on global mortality. And this is global life expectancy, an indicator you're probably very familiar with, from 1950 through to 2017. The dark line here is the global average. And interestingly, the global average life expectancy has gone up pretty linearly since 1950, allowing for the Chinese famine here, which had a huge impact on global life expectancy. It's gone up pretty linearly. Down here, sub-Saharan Africa, it did the worst. It had a period there where life expectancy was flat and even declined a little bit in the 1990s. That was primarily due to HIV/AIDS. You see the big dip here in 1994. That's the Rwandan genocide, the impact it had. And then since about 2000, this steady and impressive increase that's vastly underappreciated in life expectancy in Africa as malaria and HIV in particular in children have been dramatically reduced, and also HIV, of course, in young adults. Some of the other ones of interest here, the blue line is life expectancy in Eastern Europe, including Russia, and you see it did not do very much at all in terms of since about 1960 to about 1985. Then it decreased with the massive alcohol epidemics that we saw around the Gorbachev years, and then has not increased very much in recent years, although since about 1990, but there's been some increase in recent years as things have come more under control. The brown line here is the high-income countries like Canada and Australia. I'll just point your attention, you can't see it very well, but there's a flattening in the last couple of years in high-income life expectancy. We'll talk about that a bit more in a moment. This is a disturbing graph. This is the annual percent change in mortality for females in red and males in green, over the last 50 years, since 1970, by age, you see the massive declines in child mortality, 70%. Fantastic public health success for both males and females. For women, mortality has declined on average by about 60%, no matter what age group, and for males by about 50%. What is worrying, though, is in ages about 15 to 40, male mortality worldwide, on average, has decreased about 15% in the last 50 years. This is a major public health challenge that the GBD has thrown up. Also for females, but it's much less obvious. And we can talk a little bit about what some of those causes might be. What we do in the GBD is to try to go beyond just national estimates and talk about inequalities. So we've grouped every population of the world into what we call a socio-demographic index. Socio-demographic index is a combination of three variables: total fertility, income, and education. We take those three variables, which are very deterministic of mortality and public health in a country, and we classify every country according to its SDI score. And we've got quintiles of SDIs here from low to high. I'm afraid the highs come off at the end here, but you can see in the low socio-demographic countries since 1980 right through to 2016, just follow the red. It's come down. That means it's maternal, nutritional, communicable diseases. Massive increase in premature mortality, decrease, in the last 30 or 40 years in low-income, lowish income. It also has come down in the middle income or middle SDI populations. It was low, but has come down in the high middle, and in the very high ones like Canada, it was very low to begin with and has come down. Much less progress in the blue. Those are non-communicable diseases. The hiccup here in the high middle, that's the Soviet Union and neighbouring countries, the increase in cardiovascular disease and chronic disease mortality primarily as a result of alcohol, and the nice progressive declines that we've seen in high-income countries and non-communicable diseases. And in green is injuries, all forms of injuries. Things have changed much less dramatically. You see the Chinese famine here in the very low SDI population. But even so, the rates of decline have been much less impressive for injuries. But policymakers aren't so much interested in rates. They need to deal with the volumes of events. And this graph probably shows more what you're expecting, namely that the blue has been going up in lower income, but particularly low, middle, and middle income countries. Look at the vast increase in the volume of premature mortality from NCDs. That reflects actually the failures of our success to some extent. Those are children who survive to adulthood and older age who are now dying from and have been dying from non-communicable diseases. But the problem is that is increasing very steadily and putting a huge strain on health systems, and health systems are not adapting to that in those countries. And even in countries, the high-income countries, the volume of mortality from NCDs has not gone down. It's remained relatively constant. So it's a similar picture, but a different perspective for health systems. Now, what kills you is not necessarily, what ails you is not necessarily what kills you. This is a graph of the leading causes of disability worldwide by age, from the main causes. So age is along the x-axis here, starting from 0 right through to 95. The light purple here, at the younger ages, this is substance abuse and mental health. Look at the huge contribution it makes out of the total amount of disability coming from mental health and disability. Diabetes, increasingly important in this colour. And then as you get older, you see the increase coming in from mental health and, from low back pain and low neck pain, particularly arthritic conditions. So there's a few major conditions driving the global disability epidemic. Substance abuse, depression, back and neck pain, and increasingly diabetes. Some of this down here in green is from injuries. That's a significant amount, particularly in middle age, and some from HIV and some of the infectious diseases. But the big story for disability worldwide is from the non-communicable diseases. And that's reflected in the leading causes of DALYs. Again, you can't read this, I apologise, but it's in detail in the Lancet. It shows the epidemiological transition worldwide for male males from 1990 to 2017 in two ways. 1990 to 2007, and then over the last 10 years, what have been the changes? But just to point out, anything in red is a group 1 condition: maternal, nutritional, neonatal, communicable. Anything in blue is a non-communicable condition, and anything in green is an injury. And back in 1990, the leading causes of disease burden were pneumonia, diarrhea, and some of the neonatal conditions. By 2017, the leading cause of disease burden worldwide was ischemic heart disease, heart attacks. So not just in rich countries, but in poor countries as well, causing massive amounts of death and disability, followed by pneumonia, followed by stroke. So 2 out of the 3 leading causes are major vascular diseases, as well as some of the injuries, road traffic injuries, back and neck pain. You'll see conditions in there that are not causes of mortality, but are very prevalent throughout the world and leading causes of disability. That's for males. It's a pretty similar picture for females. Again, ischemic heart disease and stroke now up in the leading 3 causes of disability. This is global health loss from premature mortality and disability. I apologise that the numbers are very difficult to see, but if you were able to see some of it, diabetes, anything with an arrow going up is an increase in that rank. Anything with a dotted arrow going down is a decrease. But one of the bigger increases here is from diabetes, and that's both for males and females, and it's a worldwide phenomenon. We also quantify the amount of disease burden from risk factors. So this is the leading causes of risk factors worldwide. The way to interpret this is to say, if the leading risk factor in the world in 2016 was high blood pressure. In other words, if the entire world had optimal blood pressures at the exact bottom level of the risk curve, then the world global health in 2016 would have been 9% better than we measured by DALYs. In other words, 9% less DALYs if everyone had blood pressure at the lowest level that's ever been measured. Now, for smoking is the second. The second leading risk factor worldwide is tobacco. If no one in the world had ever smoked, imagine a world free of tobacco, then the world in 2016, here similar in 17, would have been 8%. About 8% healthier, and so on. So for those of you who can't see, let me just read them out. The leading causes of disease burden and risk factors are high blood pressure, smoking, birth weight and gestational age, high fasting plasma glucose, operating primarily through cardiovascular disease, that's the main driver of diabetes, and high body mass index followed by alcohol use. Most of those leading risk factors are risk factors we associate with public health in Canada and Australia, but they are global. And that's a message that's coming out of the global burden of disease. Indeed, again, apologise you can't read this, but it shows, what I wanted to do here was just take the size of a risk factor in terms of its DALYs, and look at the annual average rate of change to show which ones are increasing more quickly than others. And what you don't want to be is up in this quadrant where it's already a large cause of global disease burden and it's increasing very rapidly. And the one up there that you can't read is body mass index. The world is getting fatter very quickly. It's already causing a large amount of disease burden and it's going to increase. So all of that in summary, just 5 messages I want to get across to you. There are 4 transitions and a warning. Firstly, a demographic transition. The global disease burden is shifting from children to young adults and middle-aged adults. Young adults. I want to stress that this by any definition is premature and we need to address it. The disease transition is very rapidly moving in most parts of the world from communicable diseases to non-communicable diseases as leading cause of DALYs. The disability transition is shifting the disease burden from premature mortality more and more to disability. In Canada, in 2005, and Australia about the same year, your disease burden shifted from being more premature mortality to more disability. That is now the big challenge, and it's growing bigger and bigger for your health services and my countries. Australia was about the same time. The first country where we saw that transition from more disability to premature mortality was Singapore in 1998, and more countries are now following that disability transition. A risk factor transition where we're seeing massive changes in risk factors from the causes of communicable diseases like water and sanitation and air pollution and malnutrition to those risk factors I pointed out a moment ago, which are familiar to all of you. And finally, a warning, all of that is true everywhere except in sub-Saharan Africa, where the conditions that we characterize by the Millennium Development Goals, maternal and child health, HIV, TB and malaria, are still the leading cause of disease burden. This is a paper we published in The Lancet some years ago. It shows in orange the disease burden in 2010, and in green the disease burden in 1990, so there's been some decline. These are by the 21 GBD regions. All these regions on the right-hand side with high disease burden are Africa, sub-Saharan African regions. Down here is North America and Australia. But you can see in many parts of Asia, we've had very substantial declines in HIV, TB, malaria, infant and child mortality and maternal mortality, not so in Africa. We've made much poorer, much less progress. Okay, finally, or before I get to the implications, talking about some of the platforms that the GBD can provide for global public policy debates. And there are many of them, and I'll just summarize a few of them here. The socio-demographic index is an extremely important way of looking at how well a population is doing compared to how well it ought to be doing given its level of development. I'll show some examples of that in a moment. Also, some of the major epidemics like obesity, tobacco, and HIV is some of the things that we have been looking at, and we've recently published some forecasts that I'll very quickly summarize. So here is the ratio of the observed DALYs in countries, observed disease burden, compared to what you'd expect at the level of development of that country. And let's go straight to Canada, over here in light green. Your observed to expected DALYs are in the range of about 81 to 90%. In other words, you're doing much better than you ought to be given your level of development. I put that down to the Canadian health system, but that's an interesting one for debate. Australia's doing even better than you because our observed to, we're not doing better in too many things, but here we are. Our observed to expected is actually lower than Canada's. It's 20 or more % lower than what you'd expect given the level of development in Australia. And notice much of China we've broken it down here by parts of China, parts of North Africa, parts of Europe, and interestingly parts of Latin America as well, doing better than you'd expect at those levels of development. GBD is an interesting way to highlight that. This is impossible to read, but it's a wonderful graph of the epidemiological transition in the world in a graph. What it shows is as socio-demographic development increases, the volume of premature mortality decreases dramatically, and much of that decrease is losing all of this red, which is infectious diseases and HIV, and then you start to see some of that purple increase, which is cardiovascular disease, as you get into the higher levels of socioeconomic development. Here's HIV, we estimate that also in the GBD. Incidence of HIV peaked around the late 1990s. We've seen it come down, not fast enough in my view, males and females here. This is both sexes, but nonetheless, the epidemic seemed to peak around about 1998. Mortality from the epidemic peaked about 2005. Here's tobacco, for those of us who are working in tobacco. The fraction of adult deaths 20 years and over, this is in men, the fraction of male deaths 20 years and over due to tobacco. Canada, United States, much of Central Europe and Russia, China, some other populations like Indonesia have more than 20%, more than 1 in 5 men who die in Canada die as a result of past tobacco use. Now, Australia was there, it's on the way down, so it's 15 to 19%. Still too high, but not coming down fast enough. Sorry, this one is alcohol. We had some very nice drinks last night. It's everyone's favourite, but it shows you in the GBD we've recently published estimates of alcohol as a risk factor. This is the number of standard drinks per day. Dark is bad. You do less bad than the United States, and Australia doing worse than you and about as badly as some of the Eastern European countries, some doing really badly. Here in terms of this is 5 or more standard drinks per day. Australia is not much better than that. And this is why it matters. We do meta-analyses in the GBD. We don't just take published studies. We actually re-estimate the curve. And this is the curve that we all love to see differently. In other words, that some alcohol was good for us. But globally, there is no evidence in our study that alcohol, even at low levels, reduces risk of mortality. And in fact, it increases progressively. This, of course, is a global average. So there is really no evidence that alcohol at low levels does reduce risk at a worldwide scale. Prevalence of obesity, I thought I'd put this one up as well. It's another platform we study in the GBD. This is women this time, the fraction of women aged 20 and over by country who are frankly obese. Body mass index of 35 or more, and you can see central parts of China, parts of the Middle East. Red is bad. So Australia, Middle East, United States, your cousins below you, lots of Eastern Europe. And then the next colour down that's bad is Canada and much of Latin America. So these are high fractions. When I say bad, these are fractions of greater than 20% of women are obese, and that, of course, has significant health impact. Sustainable Development Goals, we also measure and contribute to that. This is the health-related Sustainable Development Goals. There are 52 of them. We've got evidence on 41. We put them together into a common index, and it shows how well you're doing, and we published this in 2017. Notice that Canada, the darker the colour, the better you're doing. Canada, Finland, Scandinavia are in the top category, better than Australia. We're in the second category, along with the United States. And Canada, by the way, got a score of 79 on the health-related SDGs in 2017. That placed you equal 7th, along with Switzerland, Finland, Japan, and Iceland. Very good company. There's more local GBD that we do for some countries. We're trying to be more and more granular. I'll just give you some examples. This is mapping child mortality in Africa down at the 5 by 5 kilometre pixel, just to see, to make that more and more relevant for policy. We're trying to measure child mortality at low and low levels. This is 2000, this is 2015. Notice the high levels of 100 per 10% child mortality or more in red have virtually disappeared, apart from some parts of Western Africa. We are making significant progress. Liver cancer mortality in the United States, just to give an example of the increasing granularity of the United States of the GBD in large populations, and one that I like in particular, this is the comparative global life expectancy ranking for the US counties in 2015 for males. And counties over here in yellow and particularly in red have life expectancy similar to countries in Africa. Whereas some of the counties in the US over here in the northeast have life expectancies similar to Japan. Shows you tremendous variation and what the GBD is capable of picking up. We have some work on forecasts, but I think I am running out of time. I just will show one graph of the methods. This is the predicted amount of premature mortality at the world level in 2040 from 2016. In 2040, ischemic heart disease and stroke and pneumonia were the 3 leading causes of disease burden, of premature mortality. We predict in 2040 they will remain the 3 leading causes, those that go down and those that go up. One of those going up dramatically is chronic obstructive lung disease. Another one is diabetes, as the tobacco epidemic, particularly in developing countries, unfolds. These are simply life expectancy numbers. I really don't have time, but I'll just finish off with a couple of slides on the implications. 5 key questions that I think will guide global health developments in the future. How low can tobacco use go? How much more can we drive down tobacco? You saw how important it is as a global risk factor. Even in countries like Canada and Australia, we can do better. Will the increases we've seen in obesity over the last 3 or 4 decades actually reverse life expectancy gains that we have enjoyed over the last 2 or 3 decades? What will it take to reduce the harmful use of drugs and alcohol in society? You saw how important they are as risk factors in many populations. What can we expect from better and more equitable access and compliance with established treatments for non-communicable diseases, particularly blood pressure, but also cholesterol? And finally, can we rely on scientific advances in treatments for cancer and major vascular disease to preserve life into old age? The Economist this week claimed that Japan increasingly will have a life expectancy of 100 years. I'm not sure that that's true, because I'm just not sure how much we can rely on that last point. And here's data for Canada. I pointed out earlier, and I am almost finished, that things are slowing down. Things might be getting worse now. Not in the future, but now. This is cardiovascular disease mortality decline in Canada from 1970 to 2015. Huge declines in cardiovascular disease mortality, as in Australia, UK, and the United States. But look at this little part there. The last 3 or 4 years, it doesn't seem to be going down. And when you measure the average annual rate of change of cardiovascular disease mortality, it's actually declining rapidly and going up to 0. In other words, your decline has stalled, but you're not as bad as the United States, which is not as bad as Australia. Look at those dramatic reversals in the rate of decline of cardiovascular disease mortality. This is a major public health challenge that's upon us already, to continue the decline in cardiovascular disease mortality in the face of that evidence over the last 4 or 5 years. The main conclusions then from the GBD study, they're probably pretty obvious, but let me quickly state them. Rapid and sustained decline in child mortality and maternal mortality over the last 3 to 4 decades, one of the huge things we should be celebrating. HIV deaths down by 1/3 since 2006, malaria by 1/4. Interventions are working, but they're fragile. They're dependent a lot on donor community. They need to be much more institutionalized. And that is not all. There's an urgent need to promote policies and programs aimed at avoiding premature deaths of adults, especially traffic accidents, suicide, cancers, ischemic heart disease, chronic kidney disease, cirrhosis. These are important conditions that are killing and disabling people in middle age and young adults, by any standards, premature, and ought to have greater public health priority. There's continued life expectancy gains are probable, notwithstanding what we've just seen in cardiovascular disease, but with increased periods of chronic disability. We are not seeing the compression of morbidity that James Fries and others predicted. In other words, we're seeing more and more of those extra years of life being spent with more and more disability, particularly back and neck pain and depression. Have we seen the end of the long-term decline in cardiovascular disease mortality in Canada and similar countries? And finally, there's vast uncertainty in much of what I've shown you today, and that is simply unacceptable for public policy in the 21st century. There's an urgent need to more effectively agitate for better health systems in order to improve health based on better evidence. So finally, in 25 years or 30 years, what has Murray and I and 3,600 collaborators learned? That there's an enormous global appetite for reliable, local, detailed, timely, and trustworthy assessments of leading causes of health loss in population and how these are changing. What started out as a bold but largely academic effort to quantify the global burden of disease 25 years ago has become a vastly more comprehensive, inclusive, and dynamic enterprise. I think those are all fantastic developments, providing the essential health intelligence to countries and influential and committed donors such as the Gates Foundation. What has become the largest global collaboration in health research needs to continue, but we can do better, particularly by overcoming challenges around data sharing, data gaps, and data quality. I think I'll stop there. Thank you very much.
Thank you, Alan. I think the audience will join me in saying, wow. remarkable work, remarkable body of information, and a lot to digest. We have 3 mics. I think we will take a bit of time for questions, so I encourage the audience, don't be shy. You're in front of about 400 people, so go to the microphones and introduce yourselves at the microphones. Try to keep your questions brief, and we'll try to have a rapid back and forth. So over here on the left.
Hi there, Dr. Lopez. I'm Dr. Christine Gibson. I'm a family doctor here in Calgary. I work at the Alex Community Health Center. So what I'm wondering is, if we've been measuring the global burden of disease for 25 years, but our clinical knowledge around risk factors has changed. I mean, when I studied medicine 25 years ago, we didn't understand epigenetics. So I'm wondering if we're still looking at smoking and high blood pressure as risk factors, are we missing adverse childhood experiences, the concepts of epigenetics that might underlie that, social inclusion as the risk factors that might be better public health interventions?
Good question. So the risk factors we have up there are the ones that people want to see. They're the ones that they expect to see. Doing a global burden of disease study without quantifying tobacco would be inexcusable. It does not mean that those are the only risk factors that matter. And the way we work in the GBD is something like epigenetics. If there's a community who understand the science, who can then produce the evidence that pass the same degree of scientific integrity that we screen all data sources for, and there's enough information in enough countries about prevalence of exposure and risk factors, we'd love to have it. So anything in emerging risk factors that you feel are going to be increasingly important in the future, and there's sufficient science to quantify them, like we have for tobacco or blood pressure, you should be part of the global burden of disease collaboration. We're very open to that.
Over here on the right.
So I'll say wow and thank you. So in view of the critical importance of timely intervention on all these negative trends, are you currently looking at the role of antimicrobial resistance as a risk factor so that we can hopefully educate policymakers right now in view of what's likely to happen very soon?
Yeah, very good observation, Andre. The answer is yes, but we've been very late to get to it. So antimicrobial resistance is increasingly being seen as a major global health challenge. It is currently not included in the GBD apart from multi-drug resistance, TB. And that is not the best way to quantify it, categorical attribution that we do at the moment. It's better to quantify it as a risk factor. In other words, go back like tobacco and assume there was no antimicrobial resistance, what would the disease burden be and how in that scenario? We have just started working on that. Thank you for raising it. And I direct a partnership at Oxford between the Big Data Institute and IHME, trying to come up with the first global estimates of the antimicrobial resistance burden, which will be published in our GBD 2020, if I'm still alive to make it through there. Yes,
here
please.
at the center.
Hello, thank you so much for the awesome inspiration early this morning. On behalf of all the students, I'm really grateful. But my question was, has your definition of health changed over the past 25 years? And what is your current definition of health across different socioeconomic statuses?
Absolutely not changed. We use the same definition of health that Murray and I conceived 30 years ago. In other words, it's health loss. It's not welfare loss. We try to capture health loss of premature mortality, which is pretty simple. You're dead, well, you lose health. But if you're disabled, we want to make sure that we capture health loss the same way in equivalent units to being dead. And that's what YLDs try to do. So that concept, a very, very health Nazi concept of measuring health loss, has remained exactly the same. What has changed is the way we do it. DALYs, when we first developed them, were a very convoluted construct, including discounting and age preference weighting. We had lots of debates and fights in the DALY wars in the 1990s with philosophers, and we conceded that they were right. So we dropped some of those more controversial elements of DALYs. But the concept of health that we're trying to measure stayed the same.
Over on the left, and introduce yourselves at the mic.
Thank you. Thank you very much for this amazing presentation. I'm Shahreen. I'm working at the Methods Hub at the University of Calgary. My question is more on the economic side of the presentation. So when I'm looking at the, for example, the reductions in mortality rates overall, What I'm wondering is if the data set that you have can be related to economic growth indicators. For example, the reduction in mortality could have been a result of increase in economic growth, medical tourism, and other such causes. So can we link the data that you have to economic growth indicators to look at whether the reductions in mortality rates and other diseases are because of public health interventions or other causes? Thank
You
you.
absolutely could, but that would be a great subject for bright students at the University of Calgary to do. We don't do that. What we try to do, as I showed you there, is describe the trends, measure the trends in disease by socio-demographic index. So they're there, now they need to be explained. And we haven't not done that. That's not part of the GBD. It's a great scientific challenge and needs to be done.
So one last question at the center, Mike.
Yeah, Huda Kwan, professor at the Community Health Science at the University of Calgary. I'm one of the survivors in 1960s from China. For farming time, I was survived. So I can stand here to ask you a question. My question is, I'm a traditional epidemiologist. I love your work, I love your term, but recently there are more new terms coming out, more like precision public health. What really mean of that? What mean of the precision public health? How we can apply this kind of concept from our traditional epidemiology? We are working really denominator and the numerator. Now come to try to work in one individual person. How we can switching philosophy from population-based to the individual-based epidemiological research?
I'm sure someone in the audience can answer that better than me. I'm very unfamiliar with this concept of precision population health. We do use a lot of individual level data, as I pointed out there, in order for us to understand relationships better and build models. But I don't think the burden of disease is moving down an avenue of precision public or global health. What we're trying to do is describe global health better using individual level data. I'm not sure whether that's what you mean by precision public health.
I do not know either, so that's the reason I ask you.
We're all ignorant.
So before we let you go from the podium, I just wanted to ask you one last thing, because these mega networks, you have 3,600 collaborators. That's always so impressive to me. How do you and Professor Murray rally people? Do you have 7 a.m. conference calls with all the different time zones, 3,600 people logging into a teleconference line? How do you coordinate this
Well,
group?
the best way, Bill, of coordinating is to keep Murray and I right away from it, because that's the sure recipe of disaster. No, there at IHME in Seattle there's 500 people. I remember that Chris Murray was given $600 million by Bill Gates to do the GBD or run the GBD for the next 20 years or so, so he's well financed. He's got a large group of very bright people, ranging from astrophysicists down to statisticians and communications folks. And so these sorts of networks are managed by a group of people at IHME. And what we do each year is we have review weeks, and some of you may, I'm sure, have participated. I think Salo has and others, where you come to Seattle, the teams that are working on various diseases, and the results are being presented back, the preliminary results, and criticised and critiqued. That can't be right, that's implausible. All of those criticisms we want to see from the communities. So there's an active engagement. When the papers are written, they are shared with the entire collaboration. And normally when we get any one of the papers that are published here, there's between 4,000 and 5,000 comments per paper from the collaboration, and we read every one of them. So there is an established mechanism. There's no point having a collaborative mechanism if you don't respect it and take it seriously. And there is certainly a mechanism in IHME to do that.
I'll ask the audience to join me in thanking you and congratulating you and Dr. Murray for this work. So I'm going to move right into introducing my colleague, Tyler Williamson. Tyler is a biostatistician. He's widely recognized as one of the sharpest dressed University of Calgary faculty members. And my significant other has told me I need to go shopping with Tyler sometime. he is a leader in the UCBC, so the University of Calgary Biostatistics Center initiative, and also a new co-lead of the Center for Health Informatics initiative that Huda Kwan and Cello Tonelli have been instrumental in developing along with others. Tyler's going to begin the presentations. He's the first speaker where local faculty are going to present. We've told them 5 minutes. There's a very threatening colleague here in the front row. He's going to put a sign up. If they go beyond 5 minutes, they lose Q&A time. Each presentation has a 10-minute time slot. We know that some people do need 6 to 7 minutes for what they want to share, and it's to give you the feel for the work. We will go into a break, so you'll have a chance to interact with our faculty. So without further ado, Tyler, you're up.
Thanks, Bill, for the introduction. One of the things I just learned from Alan, though, is that I need to move my entire shop to my barn. I'm going to take my team, so graduate students, pack your stuff. We're moving to the barn this afternoon. I do a lot of work. Now, how do I get my slides up here? Just a sec. That's not, there we go. Here we go. Okay. I do a lot of work in the space of electronic medical records. And more recently, we've used artificial intelligence and machine learning to try and solve some of those problems. I'm not going to talk to you a lot about EMR data. I'm going to leave that for Al. And instead, I'm going to talk to you about what's coming with artificial intelligence and some of the things that we need to think about. We're in the O'Brien Institute for Public Health, and I want to take a bit of a public health perspective on artificial intelligence and where we need to go, and perhaps maybe propose the idea that it's an industrial revolution. Artificial intelligence is all around us. We see it everywhere. There isn't a sector that isn't touched by artificial intelligence lately. It's in our phones, it's in our vacuums, it's in our movies, including one of my favorites. It's been around for a long time, right? It's in our TV shows, it's everywhere. But it's not just science fiction, it's also on our streets. And it's coming very soon, and it has real impact. Now, I have to mention, I can't skip by this without noting that all 3 of my slides for science fiction are humanoids, and Gina will talk about that, I'm certain, during her talk. But you're going to hear some excellent researchers talk about what they're doing. They're going to talk about how they're using these powerful tools to change the lives of Canadians. And at the risk of stealing a quote from Al, I didn't ask your permission. I'm going to steal this for you. You said it yesterday, so okay, he's giving me the thumbs up. That means I can steal it. That artificial intelligence is not the next big thing. It's the current big thing. So if you've been saying that artificial intelligence it's the next, it's here. It's here now. And we need to embrace it. My next question, though, is why now? I think that there are 3 main reasons why artificial intelligence has had a resurgence in the last number of years. Well, now it's going to skip ahead on me too fast. I think they are, first, storage. The second one is computing power, and the third one is algorithms. We no longer delete anything, right? I remember days when my hard drive would fill up and I'd go through and clean a bunch of stuff up. We just buy new computers or put everything in the cloud because we do not delete anything anymore. We live in a world where every day there are millions of tweets, images, posts, emails, videos. It doesn't matter. You choose your outlet. There's an enormous amount of data being produced. And the health domain is no different. We have electronic medical records, we have sensors, we have images, we have laboratory results, and many, many more. At a presentation recently, I heard that 90% of the world's data has been produced in the last 2 years, and that isn't going to change. That means that we are in an exponential curve of data production. I've also heard that if you took this, now this result is from 2013, so it's dated. I'll give you the 2020 information soon. But in 2013, in the United States alone, there was 153 exabytes of data. Now, we don't even understand what an exabyte is. But for those of you that remember CDs, many of the students, they're these round things with a hole in the middle. Yeah, they were really neat. You put them in your car. I still drive a car that has a CD player. So if you stacked them, if you put all of that information on CDs and stacked them, not in a case, just the CD itself, that 153 exabytes, just the medical data in the United States alone, would go halfway to the moon. Okay? And in 2020, there's even more. We're talking about now 2,000 exabytes is what we're proposing is going to be available in health data. In terms of computing, when I graduated high school, the fastest computer in the world was called the ASCII Red. I'm not going to tell you what year it was, so Bill doesn't feel old. But now, the ASCII Red is no more powerful. It's gone now. But my iPhone in my pocket is more powerful than the ASCII Red was. But here's the more relevant problem, is that lately there's been a resurgence of old algorithmic methods. And these powerful algorithms churn through oceans of data looking for associations. But it's not without consequences. In fact, John Giandretti, who's no longer at Google AI, but when he made this quote, he was, so I apologize for my dated slide, said the real safety question, if you want to call it that, is that we give these bias systems data, or if we give these systems biased data, they'll be biased. And guess what? We're all biased. And Gina's going to do a great job of talking about some of those issues. But I'll steal another, I'm running out of time here, and I'm sorry I've slowed down more than I wanted to. Best way to predict the future is to invent it. And so we need to be thinking consciously about where we are going and how it's going to impact society. You know, when the Industrial Revolution started previously, I don't think that we understood what impact it was going to have on society. Now here we are at the O'Brien Institute for Public Health, and I'm thrilled about what the future is going to bring in the world of AI. But we also have to be careful and cautious. When the steam engine was rolled out, I don't think that we understood then what impact it would have in the future. I don't think that Henry Ford had any idea what influence vehicles would have on our society. A huge public health risk for us now, but something that we need to think carefully about. Artificial intelligence is here, and it's changing the way that we do everything. But we need to think about that we need to think about the future carefully and judiciously and the impact that it's going to have on public health. And with that, I'll take some questions.
So Tyler will be moderating after this, but I'm moderating his presentation, the Q&A. There's time for questions or reactions. There's someone coming up, middle mic.
Hi, Eric.
Hey there.
And rapid fire questions and
Sure.
answers.
Elon Musk is very wary about the possible negative consequences of AI. And he has a big, kind of argument, for example, with like Zuckerberg on that. Zuckerberg's all like, woohoo, and Elon Musk is like, no, we could die. What are your thoughts on that?
Boy, so it's funny that you asked that. I contemplated actually leading with, Elon had a huge tweet that was like, retweeted thousands of times that said that artificial intelligence is potentially more dangerous than nuclear weapons. And I thought about titling my talk something around that to be a little more provocative, but then I decided that I'm not sure that I agree with either of them, which is a dangerous place to be because these are brilliant men. But I think that the point that Zuckerberg is making is that artificial intelligence has a great capacity for us to improve lives, and I genuinely believe that. But I also think that we need to be thoughtful and careful about it, just like any other tool. The invention of fire was a great thing for early man, but it also kills people. And I think that we need to think about it in sort of that way and how we carefully govern it. So I'm kind of straddling the fence there, if that answers your question.
Okay, and maybe one more at the center mic.
Yeah, Alan Conway, former business school dean. One of the issues with AI is this inability to audit. And when it comes to things like healthcare, many important things, that's going to be kind of a critical, almost debilitating aspect of our adoption. Any comments on that?
So I think that you're talking about two issues there. The inability to audit partly comes from the proprietary nature of some of the AI algorithms that are built. And I think that that's a different problem than others have complained that, well, it's black box, you can't see into it, and therefore we can't understand what's happening. I'm not sure that that's accurate. I think that part of that is that we don't do a good job of explaining them. Again, I'll give a shout out to Eyal, who presented yesterday and talked about this very issue and said, I think if we did a better job of trying to explain it, I think that we could explain it more efficiently. And he did a good job of explaining how deep learning happens in a few seconds with a demonstration. And so I think there's two issues at play there. I think that we that use AI need to do a better job of explaining it and understanding it ourselves so that we can explain it to others. But I think there's a proprietary issue there that's a different one. I don't have time to comment on, unfortunately. I'm getting the red card.
Okay.
Grateful to have the opportunity to introduce some speakers here. The first speaker is Dr. Lorian Hardcastle, who's an assistant professor from the Faculty of Law at the University of Calgary, and she's going to talk about big data for health and the law.
Well, thank you to the organizers for putting together this great event. I would normally say more pleasantries, but in 5 minutes, that's going to be it. And this is good practice for next week. Next week is the last week of classes when I plan to cram 4 hours of material into 2 by talking really fast. So this is perfect dress rehearsal. So I could have picked on a plethora of legal issues to focus on. There are many in the context of big data and AI. I've picked a few. But what I want to encourage you to do today is to think a little differently about the law. I think the law is often sort of an afterthought, a source of annoyance, right? You've come up with this really cool project where you're going to link up these databases and come up with new and interesting data. But the law is saying you can't do that because linking them up, it becomes the anonymous data become identifiable, and so the law is just a source of annoyance in your great research plans. So I want you to think about it a little differently today, and I want to think about how the law is something that can actually, AI and big data can actually facilitate clinicians fulfilling their legal obligations, and how, if we think about the law further upstream, we can build some of that into the way AI is designed and is rolled out. So the first issue that I wanted to talk about is liability, every clinician's favorite dark cloud looming over their head. But in some ways, we're concerned that these new devices will result in new forms of liability, or that if we rely on certain kinds of devices that we could be at risk for being sued. So two things I wanted to say here. And the first is that isn't always the case. In some ways, these technologies can actually help people fulfill their legal obligations. In some ways, these new devices or new technologies don't cause liability. They actually help you to avoid it. And so just to give you kind of a basic example of that, on your left you see Alexa, and one of the ways that Alexa is being used is to give physicians the surgical checklist as they're gearing up for surgery. And so, that's the sort of thing that if a human does, it could be prone to human error. You get distracted somewhere in the middle of the checklist, but if Alexa's telling you, there's less room for that. And for those of you who aren't clinicians, the surgical checklist is such things as, is this the right patient? Are we operating on the wrong side of the body? And for those of you who aren't doctors, might not know this, and it's horrifying, but people have had the wrong limb cut off or other such things. So this is, these are important checklists. And so to the extent that we can automate those, technology can actually be a way of avoiding liability or of enhancing quality of care. Where things get more interesting, though, is when we're looking at technologies like Watson that aren't maybe complementing the decision-making process of physicians, but in some ways could potentially usurp that decision-making process. And so these are things like the algorithm that is as good as dermatologists at detecting skin cancer, or Watson can read CT scans and detect the risk of stroke. And so, we're at the point where some of these are as good as, or in some contexts, even better than clinical decision making. And so when we start to rely on those, are we challenging the traditional ways that we think of liability, which focuses, of course, on the clinician and them having the kind of final say, to the extent that, we're relying on these sorts of devices as actually being more reliable than clinicians, what does that mean for liability? And what that could mean is that locus of accountability or liability shifts from physicians to the institutions who pick which technologies to adopt or how they're adopted, or even more likely to the device manufacturers. And so there's a lot of discussion now, and the law is being sort of proactive here around how are we going to regulate these medical devices. And so this is an area that Health Canada is doing a lot in right now, and you'll see not just Health Canada, but the US FDA and other regulators, and you'll see the phrase software as a medical device. And so, when we historically thought of medical devices, we thought of a thermometer or a pacemaker, and how should we regulate those? But now we're getting into discussions around software as a device itself. And so Health Canada is currently consulting on that very topic. So I wanted to hit on one other liability issue, and that is the issue of consent. And again, this is a sort of rah-rah, the law is great example of how the law can sort of positively complement, or how technology can complement legal obligations. And so right now, consent has objective elements, and it has subjective elements. And so you're probably very familiar with the objective elements, which is when the doctor reads off the list of what we would call in the law material risks, or risks that a reasonable patient would want to know before undergoing a procedure. And I think we do a good job of that. Where it's more time intensive and more difficult to do is the subjective side of consent, which is does this patient understand what I'm saying? If they speak a different language, or if they have diminished capacity, or how do we take this patient's preferences and integrate it with what we know about the objective medical risks? And so, I didn't advance the slides properly, sorry. So technologies like chatbots that can interface with patients can actually help to enhance that subjective piece. And so to the extent that a patient is interacting with one of these devices, it's maybe able to appreciate that this patient maybe doesn't actually understand the risk information, or it's able to integrate some of those subjective preferences with the objective medical risk information. And so in that way can actually enhance that subjective piece of consent that I don't think medical professionals do as good of a job as they do of the objective piece. So I'm getting the time's up face. I've already got the time's up sign. The time's up face is sort of the next level. So I'll say one more really long sentence, and that is just to say that, I want you to take away from this that, the law isn't always sort of this barrier or this obligation. These technologies can actually be designed in a way that helps to fulfill some of these legal obligations around enhancing the consent process, or avoiding liability, which is also making care safer. But that we need to think about it at an early stage, not I have this great technology, now how do we get around this legal stuff, but further upstream as this technology is being designed and rolled out, how can we account for the law at that upstream point? So we still have a couple minutes for questions, or did I just talk for the full 10? No.
Yeah, we have a couple of minutes for questions for sure.
My goal was to talk for the full 10 so that nobody could ask any questions.
Are there questions? Gina, here, you can have this mic right here.
Very quickly, we just heard recently that IBM Watson for Oncology was pulled from a hospital where it was being rolled out because the data being training the model was actually on hypothetical situations and not on real cases. What happens when models are wrong?
Well, I mean, humans and doctors are also wrong. I mean, the standard in any sort of liability issue is reasonableness. And so was it reasonable to rely on that data in the first place? Was, whatever the data spit out with regard to an individual patient, did it seem reasonable, with regard to that actual patient? So the law does give a bunch of leeway, and the courts will distinguish between errors in judgment and negligence. And so errors in judgment are fine as long as, like, you can go ahead and misdiagnose someone as long as that misdiagnosis was reasonable. And so as long as the adoption of that technology was reasonable and relying on those hypotheticals was reasonable, and clinicians were taking the information they were getting about specific cases and applying it in a reasonable way, then it's fine. But there is a class action right now going on in the US where an electronic health record failed. There were just failures in the system, and someone died, and so there's some liability questions around that. But so it's not impossible that those kinds of systems can result in liability.
Thanks. We have go over here to the left. Thank you.
Hi, my name is Jenny Godley. I'm a member of the Research Ethics Board here, and I just wanted to thank you for your presentation and to encourage all the researchers in the room to also see the Research Ethics Boards this way, which is that we're there to help, and I know that you don't always think that. And also, there are definitely issues that are coming up with this kind of research, especially around, as you all know, around anonymous data and merging data sources. I myself have gone through many of these, have had to go through many of the applications. But we are there to help, and there are lots of ways that we can think about data differently to make sure that we protect our subjects. And that's really the main objective of our boards.
Thanks. Yeah. Do you want to respond to that? Or? I don't know there's much to say. But.
No, I think I also sit on a research ethics board here. I guess it's a different one, but the other one. But yeah, no, and I think, I sort of joke about the law being a source of annoyance or an inconvenience, and in some ways it is, but I've never run into a clinician that doesn't, sort of appreciate that even though, in this particular case it might be a source of annoyance, that, privacy is important, consent's important, like these are important values, so.
Yeah, thank you. Now, it's my privilege to invite to the stage Dr. June Lee, who's an associate professor in the Department of Community Health Sciences, which I'm super excited about because that's my department. And he was formerly at Waterloo, so we completely stole him from Waterloo. And you're going to hear about the awesome work that he's doing here in Calgary now that he's here. Go ahead, Jim.
All right. Thank you so much, Tyler. So I only have 5 minutes to talk about this, so I'm going to speed up and power through this. But today I wanted to talk about not my past research, but something that I've been thinking about for a while. And it's a bit of a futuristic idea, but I just wanted to throw it out there and start to think about this all together. So the title is a digital health assistant, and we all use these digital assistants now quite frequently. Siri, Google Assistant, Alexa, and these things are usually good for fairly simple tasks. So if you want to look for a certain piece of information on the web, then you ask it, and it's going to find it for you. If you want to turn on a light in your room, then it can do it for you now, and so on and so forth. But when it comes to health, there isn't much that can be done other than to ask some simple questions like, I think I have some symptoms, what might be wrong with me, and it's going to try to find the information on the web. Could be wrong, could be accurate. So, it will try to find answers on the web, but that's pretty much about it. So can we, take it to the next level and ask questions like, how is my health? How am I doing? I have these chronic conditions, and how is my lifestyle? Is there anything that I can change? Because you've been monitoring me, for the last, years and days and weeks, and based on your observation, like, what can I change? So that's the basis of this whole idea. And I talk about the chatbot part just to gain some interest because that's the fancy part. But the chatbot is really just the user interface. So what I really want to talk about today is what happens under the hood, which is the data part. Because the digital assistant will have to understand your health in a personal way. And the only way to do that is to do that through data, right? And I just want to highlight the current problems with health data in general. And I have this little plot here that shows health data volume as a function of time. And you see these spikes. So when we get sick and when we show up in the healthcare system, when we are visiting doctors, pharmacists, labs for blood sample tests and whatnot, that's when these data are generated. But what about in between though? And as we heard from Dr. Alan Lopez this morning, there's a lot of emphasis on our lifestyles and so on and so forth because of diabetes and other non-communicable diseases. So these gaps need to be monitored, and I kind of feel like we're only working with just a few pieces of the puzzle because we don't have the whole data set that will have a bearing on our health outcomes and our adverse events. So in order to support that even further, if you look at determinants of health, which have been mapped quite extensively actually, I want to highlight that there should be an animation playing. Only 11% of all the determinants of health are about medical care, and 21% coming from genetics and genomics. But most of the stuff are about our lifestyles and behavior. So it's not crazy to say that we should be monitoring these risk factors on a daily basis because these things have a lot of influence on what's going to happen to our health. So what can we do about it? And up till a few years ago, there was no good way of monitoring our lifestyles and so on. But now we are increasingly starting to think that this is actually possible because of the mobile devices that we carry around all the time. Our smartphone is with us all the time. It's got lots of sensors. And if we can keep collecting data about what we do every minute, every hour, where we are, and connect them to information on the internet, then we can start to aggregate very rich data source about our lifestyles and behavior. And I'm not trying to downplay the importance of medical data and genomic data and so on. As you saw on the determinants of a health map, they are important. But again, those are just few pieces in the puzzle. We need to have all pieces of the puzzle to implement precision medicine. So I'm sure you've heard about something like this or seen something like this in movies, like the movie Her, of course without the romance. But this I think is something that's feasible and something that we can start to talk about. AI, as Tyler said, is not something that will happen in the future, but it's actually something that's happening now. And if you think about all the modules that go into building such a digital health assistance system, natural language processing, AI, machine learning, big data analytics, all these things are advancing very fast. So integrating all these technologies into one piece will be a daunting task, but it's something that we can start to talk about. Thank you so much.
Thanks very much, June. So we have some time for questions for Dr. Lee, if there are any. Dr. Gallagher.
Thanks, June. You alluded to the back end, that you're interested in how it works under the hood. Can you just give us a little bit of a technical feel? Because obviously things like this, these concepts, it's like magic. I always find I'm blown away by my phone. Mm-hmm. What's going on under the hood?
Yeah, sure. When you break it down, data collection is the first part, right? So using the sensors and your activities on the internet, and these things are being monitored and they are going somewhere, right? And once you can get a hold of all these data sets that are about your lifestyles and what you're doing, then you have this huge, and this is a true big data that's really difficult to manage and mine. And this is where it gets really complicated and difficult to extract useful information from. But once you can do that, then you can start to look at individuals as different people, and because all of us have very different data sets when you compile such a rich data set that has many different variables, and then we apply machine learning. We learn from the data, a very rich data set from many different individuals, lots of data points, very longitudinal. And we can try to come up with algorithms that can inform us. Yeah.
Thanks. We have another question over here. Don't forget to introduce yourself.
Hi, Heather McIntosh from the Engagement Hub in Medicine. The American Civil Liberties Union has for many, many years raised concerns around monitoring of lifestyle and health-related behaviors and the impact that they think that might have in refusal of medical insurance in the United States. So I just wonder if you could comment on those risks.
Yeah, sure. These issues are becoming more and more important. Equitable use of AI, fair use of AI, all these things are becoming very, very important. One thing that I can think of is, we have to make sure that we are not discriminating certain individuals for the wrong reasons, right? If there are real risk factors that will, push us to the right conclusion, then that's what we need to embrace. But if somebody is being denied for a certain thing just because they are, because of their skin color, where they come from, their education level, their income level, and so on and so forth, then that's not something that we can embrace as a society. So, and all of that, if you think about it from a technical perspective, it really depends on the data where the algorithms are based on. So if you don't have good representation from all different subpopulations with the different backgrounds and so on in your data set, then your AI algorithm will be biased because that's what it's learning from the data. And it's often easier said than done, having good representation from all different individuals, especially when you're thinking about precision medicine, because there are so many different kinds. There's basically infinite number of different combinations of all these variables when you have big data. So it gets challenging, but it's something that we need to think about and check on an ongoing basis.
Thanks. Dr. Dickinson. Please introduce yourself, Jim.
Right. Jim Dickinson. I'm a family physician, general practitioner. I'm concerned about this concept of data. Yes, we can get a lot of data from my movement day to day out of here. But in general practice, we're at the fuzzy end of medicine, where a lot of the time people come into us with vague and uncertain symptoms and problems that we have difficulty working out, most of which will get better if we leave them alone. And only a few actually enter into the nice, well-defined algorithms that our specialist colleagues use. And most of the time, so most of this data is actually not useful. What the data that Tyler was talking about, an awful lot of it is just rubbish. And how are we going to distinguish the rubbish data that really doesn't mean anything very much at all, like, who chose to eat which fruit this morning, versus things that actually matter? How are we going to distinguish that in order to pick out the things that really matter? That's what we do in general practice all the time, trying to decide, does this person have something that needs an actual treatment or not? Does that person need to see a specialist or not? And that's actually a really difficult task. It's all very well to talk about the ability of dermatologists to look at, to decide, is this a skin cancer? But that's actually a very simple thing to do once you've actually decided to get them into the algorithm.
So
what goes in?
Thanks for that, Jim. So June, that's a huge question. Now, good luck. Good luck. I'm going to leave it to you to answer rather than I'm not going to touch that one. And try and do it in a brief way. So good luck, my friend.
Okay, my short answer to this, first of all, I agree completely with all the concerns, and that's why this is a big research topic, right? This is the crux of the data science research that's required here. Data won't be clean, data won't be optimal in terms of quality. So how can we squeeze that and get what we want out of it? And how can we find the true underlying phenomena that are that can be applied to many different cases? So that really is the challenge. Yeah.
Yeah. Thanks for that. It is my privilege to welcome to the stage Dr. Sheila Carpendale. And unfortunately, I'm going to tell you a story that is a little bit different than June's about how Sheila has unfortunately moved to a different university than the University of Calgary. And I'm going to talk about how SFU has done a coup on us and stolen Dr. Carpendale back to, or out to them. And apparently, I'm going to kill some time while they load up a presentation as well. Anybody know any jokes? I'm just kidding. So, but maybe Jim, actually, I'll take the opportunity while I wait to add something to what June said about your question. In that, I think that the reality is that the data's here, and distinguishing between messy and clean data, not going to be easy. There's no doubt about that. But I don't think that it's a problem that we can avoid. I think that we have to do our best. Some problems we will never be able to replace. Some we may be able to. Okay. Dr. Carpendale, please, go ahead.
Okay. Yeah, so I had actually thought I would do this without slides. And, I have to use the mic, yes. I will stand a little bit to the side. I always feel like I'm drowned behind these podiums. So yeah, I'm going to talk about health data and the individual. I like to always first acknowledge my students because they're the ones that do the real work, and many of them are here amongst you. But this year, all of these students graduated. 6 of them are PhDs, and you might notice that for a computing science lab, this is an unusual grouping of who happened to graduate this year. So the idea today is I want to convey one basic idea, and that there is a large problem that is rising from technology's notion that there's a need for generalization. And actually, there is nothing inherent about technology that says that everything has to be generalized. We've just kind of bought into it. Truthfully, it's kind of better money-making. But I think we have to actually rethink looking at how we can make technology for the unique and the specific. Okay, so I've always approached my work by thinking about how can we think about this more broadly. So I'm going to give you a few examples so we get some pictures of where we've taken a different tact. This was actually in chemistry, and we were looking at how, so this is a new visualization that was invented to get a better look at how free radicals in a water solution that's like in your body can self-neutralize under the right conditions. This one was something done with Dr. Hill, who may even be here, I'm not sure. But instead of looking at the usual kind of health data we looked at their process data, like how long it took for a patient to get to the door to a particular room. So we looked at treatment data, and it was part of a large movement that he was doing to shave off minutes in stroke treatment, really including improving people's qualities of lives afterwards. This is prompted by our librarians who are really worried about the library going digital because of search all being targeted. And actually, we as humans don't tend to use targeted search. So we created a new interface specifically designed to increase serendipity. And you can ask me more about that later. One of the things that I'm worried about with all this big data is that we're developing a new elite, those people who work with data. And I think that we, who have taken on trying to make data understandable, have to actually do something to counteract that. And as part of that, thinking about inclusivity and diversity, I have a really big project with 6 or 7 people right now, some of whom are here, with the Canadian National Energy Board data to actually make publicly understandable what's happening with energy data. This is actually a visualization of pipeline incidents, so you can go and look up and explore what different incidents causes, where they are, those kinds of details. This is visualization using Aurora Max data, where we're looking at the Aurora Borealis, and you can see that it's in a public space, and it's designed to attract people as they walk by. But further than that, if we really want people, like how do we become literate with words. A lot of it has got to do with being able to author, just write a few sentences, a few paragraphs ourselves. So if we want people to be visualization data literate, can we actually help them author things? So based on inspiration from Froebel, Piaget, and Papard, we thought, let's look at this. Let's study if we give people simple wooden tiles that are colored, data that they've seen before, like a bank statement, can people who have been demonstrated to not visualize very well do it themselves? And definitely they could. They made all kinds of visualizations, and these are just people off the street, no particular education. This technique is actually now being used by the UN to help small governments learn how to think with data and what it means to base decisions on data. But maybe authoring is not enough. We've also been looking at reading and how do people actually try and read and understand a visualization, and can we support that with the kind of interaction there is? We've been looking at data comics, and then very recently we're actually looking at, can we use data comics in health to help convey information more simply? And with personal data, again, giving people physical means to visualize. All kinds of people had no trouble visualizing their own data. All kinds of people had really powerful self-realizations. And this last one is the point that I actually really want to make, that when we were looking at personal data in health, and we were working with very ill people, each person was really unique in how they collected their data, in what data they were collecting, what they'd been asked to collect, whether they chose to themselves. So Fatima, whose project this is a large part of her PhD, developed a whole design space, specifically thinking about the patients and their differences and what they actually kind of wanted to see out of their data. And then we took it back to their caregivers, and we discovered that, of course, it's obvious they had completely different reasons why they thought this might be a good idea. They wanted a holistic overview. They wanted some of them wanted collaboration between the caregiver and the patient. Some of them wanted the patient to be more self-exploratory. These are also unique. And then, though I had actually thought that we would make this design space to generalize, I no longer actually think we should generalize. We should actually allow people and caregivers to have freedom of choice, and there's nothing preventing us in technology to have that kind of freedom of choice. And this has been, like, forever. Health has been based on one patient and one doctor, and it has been very individual, and there's no reason why we can't benefit from data, from technology, and still maintain this one patient, one doctor. So a large part is the problem is technology's notion that there is a need for generalization. So I don't think we should generalize. I think we should design for the specific. And I've probably used up all my time, right?
Thanks, Dr. Carpendale. I always enjoy hearing you talk, actually. Your work is incredible, so thank you. We do have a few minutes for questions, if there are questions. If not, then I will gladly monopolize the question time. So, since I'm holding the mic, I've heard it, you talked about how we need to not I actually wanted to disagree with you when you said that we've created a new elite because those that work with data are the elite, and I actually kind of liked that idea. But I've also heard it said that the scientists of tomorrow, or the AI scientists, the big data scientists of tomorrow, are the scientists of today need to be tomorrow's ethicists, because there's a huge issue around, like, equality, and you touched on that briefly. That we need to be thinking about as we put these tools forward. Maybe I'd ask you to comment on that. So
I'm not sure exactly what you've asked.
Fair enough. Yeah. So what I mean is that those that are going to be those that are empowered to have such data literacy in the future are going to be in a position of great power, right? That's what you were saying?
Okay, I don't think so. Okay. I think our education is, not properly serving everybody. There's no data thinking in public schools. There's none in high schools. There's none in, well, that's not true now. We actually have that here at Calgary. We have a first-year data thinking course that's open to any student, and there are people lining up to get in. Yeah. And basic data literacy is now something that I don't think there should be an elite. I think that it's something that's a right that everybody should have. Everybody should understand. And I think that you can only actually start thinking about the problems of basing stuff on data when you understand how it works.
Yeah, I think that's a great comment, so thank you for that.
It's my great pleasure to introduce the next featured speaker today, my friend, Professor Gina Neff, who I have known for a number of years, and I won't say how many, but we met on our first day of a PhD program in New York City. And I'm very thankful for the chance to bring her to Alberta for the first time because of the Gairdner Foundation and the O'Brien Institute. So Professor Neff is a senior research fellow and associate professor at the Oxford Internet Institute and the Department of Sociology at the University of Oxford. She holds a PhD in sociology from Columbia University, where she remains a faculty affiliate at the Center on Organizational Innovation. She studies the future of work in data-rich environments. She is an expert on technological disruption across several different industries, including healthcare, media, and construction. Professor Neff has published 3 books and over 4 dozen research articles on innovation and the impact of digital transformation. Her most recent co-authored book, Self-Tracking with MIT Press, focuses on the practices and politics of using consumer technologies to track health and other everyday personal metrics. Her book, Venture Labor, Work and the Burden of Risk in Innovative Industries from MIT Press, about the rise of the internet industry in New York City, won the 2013 American Sociological Association Communication and Information Technologies Best Book Award. She leads a new project on data diversity that studies the challenges of using artificial intelligence for decision-making. And her writing for the public has appeared in Wired, Slate, and The Atlantic, among other outlets. And on a personal note, I'll just say that if I had to choose one word to characterize Gina Neff, that word would be generous. She's a generous friend, a generous mentor, and a generous colleague, and I'm very glad to welcome her here.
It is a great honor to be here today. Thank you for the invitation. Thank you for the fabulous conversations that we've been having over the last day, including the AI and Health Day that we had yesterday at the School of Medicine. So, and thank you, Ariel. I'm a sociologist, and I'm here really to speak to this word that we have in the title of today's event about expectation. So I've spent time studying how people think about their own data and the kinds of self-tracking projects that they do. I worked for 3 years on a project with Intel on the future of these commercial-grade devices, and my remit really was, how are doctors going to respond when we all, like Rachel Kalmar here in this photo, have our own personal self-tracking data that we bring in to the clinical space? Are clinicians going to reject this data? Are they going to be territorial about this kind of data? Or are they simply not going to care? So what I really want to think about with you is when we're talking about data transformations of health, can we look at this interaction between people and their expectations for how they have clinical conversations and what they want to have happen with their data, and the ways in which perhaps those expectations aren't being met, and maybe those expectations are being taken advantage of. So that's kind of the broader scope of what I want to talk to you this morning. But first, a little experiment, and I want to see a show of hands. So here we have, I love this photo because it's a designer of fitness trackers. And in our 3-year study, we started looking at how fitness trackers would be a model for thinking about consumer biosensing. And as you all know, consumer biosensing isn't really here with us yet. We don't have these kinds of off-the-shelf consumer-grade technologies that are gathering blood, sweat, and tears and giving people some kind of biometric from that data, but they're coming. So, fitness trackers. How many of you have used a digital device, whether a wearable or your smartphone, to keep track of some kinds of health or wellness information? Show of hands. Okay, keep them up for just a moment. Look around, everybody look around. When I started this project, usually only about 10% of the people had them up. Keep them up, please. How many of you still use that device on a regular basis? My talk is done. You can put your hands down. So we know that there has been an explosion in this self-directed tracking. And we also know that about 60% of these devices and practices really only stay used for less than 6 months. So something is going on where people are either getting their needs met from a short self-tracking experiment that teaches them how much activity they're getting in their day or whatever their kind of goal of that tracking experiment is, or the data aren't meeting their needs. And this is where I want us to use this process as a bit of a thought experiment for thinking about digital health more broadly. We heard great talks this morning, really incredible talks about big data and global public health. And the shocking news that what we have thought of as first world problems, these problems of obesity, these problems with high blood pressure, these problems from diseases that we know individual behavior can help mitigate, are now global public health problems. So on the one hand, we see the rise of conditions where people's individual behaviors could help them lead healthier lives. We see the rise of new tools and technologies to help them make those choices. And yet, something's not happening in that connection. Why? Might be the answer that a sociologist would ask. So, one of the things that I did with this project was think about how data are talked about, how people have certain kinds of expectations. And I spent a lot of time with people working in the digital health space, designing technologies, and listening to what they wanted the digital health data, digital wellness data to do, how they thought it might transform clinical conversations, nudges for personal choices and actions, etc. And so I worked with a designer to come up with really a model. So if our data is part and parcel of a larger economy of being bought and sold, if data really is this kind of object in an economy where it's transferred to third parties, people don't fully understand what it is, what would it look like if it were a product? What would it look like? What would data look like if it were on your supermarket shelf? And so working with a package designer, we came up with this data box, right? What if data were simply bought and sold like a laundry detergent? And I use this image simply to introduce the kind of 3 key points from my field of science and technology studies and the sociology of data that I want to bring to audiences like this that are people generally interested in health. And the first would be that the data about people are made, right? They're made, not found. And that this is an important point in designing kinds of programs to help people live healthier lives based on the data that they have about themselves. The second would be that data do not simply equal action, that simply because we gather data, simply because there is data, it doesn't necessarily lead to a set of decisions and actions in place. And this has enormous implications, I think, for the inequalities of health. And we'll talk about that point as well. And then finally, data about people really aren't off the shelf. We just had a fabulous talk about this drive to generalization and the drive to make equivalent different kinds of conversations, different kinds of expectations for data. But once we begin to recognize that individual context and environment have an enormous impact in how people make sense of their own data in their own lives, then we begin to open up new possibilities, I think, for digital health. So let's take the first point. In our book, Self-Tracking, we wrote this really as an explainer for the public about the rise of self-tracking, historical precedents for self-tracking data, and we focus on health and wellness tracking, although we use other kinds of self-tracking projects. In the book, we follow the community quantified self and look at some of the sometimes wacky experiments that they do. And one of the key insights that we want to bring with this book is that when people set out to do self-tracking, they are making data not just with those devices, like the ones we saw strapped to Rachel's wrists, but they're making it also with the practices that they have in everyday life and the communities with which they try to make sense of that data. And this connection between the technologies, the everyday practices, and the communities ultimately shape how people expect their data to move, what they expect and want from their data, and how they make sense of it, what they can actually do with these kinds of data. One physician we interviewed early in the project, when we said that we were working on this project on self-tracking data, we then asked him, so how are you going to respond when someone brings in their smartwatch and says, "Doc, what do you think?" And he said, well, first, what condition do they have? Which to us as sociologists, we're like, condition? Why would you ask that question? That was supposed to be a joke. Little relief. So from our point of view as advocating for the kinds of practices that we could foresee were coming, we said, no, people are going to track things about their health, and they're going to want some interpretation about it. And he said, this beautiful quote, he said, I know what to do with 3 blood pressures taken in my office. I have no idea what to do with 20,000. We know that many people are gathering data that might help them change their lives. And yet, the kinds of communities that they have to bring medical insight to that information are now lacking in the current moment. Let's look at 3 stories from the book. This is Chiara. She's an economist, incredibly sophisticated with data. She is what we might say these data elites. She's wearing a now out-of-business self-tracking watch, the Polar Watch, which she really loved because it gave her the clearest access to raw data. And being an economist, working with data for a living, this is what she wanted. What we've learned from interviewing dozens of people in quantified self communities, people who are managing chronic conditions in their daily lives, and doctors who are trying to improve patient-doctor communication, is that these self-directed experiments change the possibility of who asks questions. Now, for some in the quantified self community, these questions are a little wacky. If you're a scientist, they're not really valid. For example, if one were to take an example from a quantified self demonstration, if one were to track which cardinal direction you were standing over the course of the year, could you tell a story about how facing north makes you less depressed? Yeah, sure, maybe. That may not be the kind of question that a neuroscientist would ask, but it is the kind of question that someone has asked about their health, and they are asking about their life, and they're trying to make some kind of meaning. And so the possibility of having kinds of data that people can query and ask new sets of questions opens up new kinds of possibilities. So one of the arguments we make in the book is that, well, maybe these fitness trackers that get left behind after 6 months are not allowing people to continue asking the next question. And it suggests that perhaps We need to think about this not as a public health nudging device where health experts are pushing people to make healthier choices, but rather, can we think about these self-tracking devices as new ways to open up scientific engagement and scientific inquiry more generally? This is Hugo Campos. Hugo became an activist for the right to access his own data. He had an implanted defibrillator, and when he lost his health insurance, this is, of course, a US story, when he loses his health insurance coverage, he wants to be able to monitor his condition and to see when his defibrillator is firing. He also wants to ask questions if there's certain foods or certain moments in the day that causes his heart condition to be worse. So is eating a ham sandwich at lunch, for example, something that might trigger an episode? So he did what any reasonable person would do. He went to his doctor and he said, I'm about to lose my health insurance. Can you please help me get access to this data? The company denied his request, and he took this request all the way to the Obama White House, where he became a public advocate for people's rights to data from their implanted medical devices. Now, he said, it's my body is producing this data, it should be mine. The company finally relented and gave him access to the data, but they didn't change their overall policy, so his victory was a bit hollow. It was a victory for him personally, but not for patients in general. And so the moral of Hugo Campos' struggle about getting access and control over his data is that we need to be careful when we're thinking about digital health, that we're not disguising a sense of empowerment and control over data as something that really is a burden that we're placing on individuals, that we're actually addressing the core underlying problems around equity and justice in health, and not simply saying individuals can take more control of their health if they can take more control of their data. And finally, this is a picture from our study from a Medicare demonstration project. And this was a study of a telehealth program in rural eastern Washington with elderly patients who were struggling with at least one chronic illness. And in this study, time and again, people came back to photographs and experiences of these. So this is this is kind of the flagship photo from this telehealth study, where care workers didn't actually see their patients in person that often, but they used this moment to think about how the data that they shared on a daily basis became this possibility and moment of connection. And so when we think about these kinds of vast amounts of data that are being collected about us in our name, the kinds of social media data that might be marshaled for public health, we need to remember that these kinds of data can be, they can serve as a possibility for more connection and better conversations with care providers, or they can be seen as something that's taken out of context about us and jettisoned off and speaking about us, not for us. So now I want to talk about my second point, really, this question that data do not equal action. In one of our first interviews of the project, we went to a physician and we said, so there's going to be all this great new data about your patients. And very quickly, he said, I don't need data. I need resources. And this is striking, and it was very striking for my Intel collaborators because the idea that data are not a resource was shocking, right? That's heresy in Silicon Valley. And yet, when you talk to overburdened clinicians, they often, as we heard from the gentleman earlier, they're dealing with fuzzy problems. And it's not necessarily better, finer-grained data that's going to help them solve those problems. Not in all cases. I want to be clear not to overstate this point. That the data, because data are collected, doesn't necessarily lead to the fact that more interpretation and better interpretation can help improve people's lives. And again, I'm talking about the clinical experience, not necessarily in larger scientific discovery or in terms of these larger public health issues. So this is the dashboard. This is the desk of the one of the care workers, the nurse practitioner care workers that was in our Medicare telehealth study. And what you see is actually a very old system. It's not smart, it's not AI, this is not the AI apocalypse. It was simply a dashboard that parsed data that the elderly participants would enter in every day. And these devices they were using were pre-smartphone era. So these were very simple to use devices that didn't assume that they had wireless or internet access in their homes. So on the top row, we see the data for Mrs. Jones, a pseudonym here. And Mrs. Jones always showed up as red. And the care workers all knew that. They knew she showed up as red because the system was built to say that if someone weighed under 100 pounds, that was enough to trigger a follow-up phone call. You need to check in on this person who is elderly, and in her case, slight and small. And yet, what else do we see on the page? We see this list that the care worker has put in front of her to do her follow-up calls and her follow-up interviews. So the data really became the starting point, not the end point in clinical care. It became the excuse for a conversation that would happen. And frankly, it was probably that daily conversation that helped the people within the study improve in their outcomes. So the study actually showed vastly improved patient outcomes, but it was expensive. And Medicare stopped the project. Why? Because the data themselves might have been relatively inexpensive to collect, but putting medical expertise and interpretation into that moment and having that conversation available to patients as an extra level of care may have improved outcomes, but it meant that there had to be other kinds of resources, time and clinical time, that were brought to that interaction. So that these actions, deciding what to do about the data, actually were costly. And this would be my second caveat that I would say about how we need to think about the expectations of digital health, that just because we can collect the data doesn't mean that we can provide care around these data, and that expectation needs to be monitored and managed. And finally, my last point about these kind of 3 points are about how data about individuals really need to understand context in their own lives and how they're not on the shelves. This is the logic model from a program at Cincinnati Children's Hospital through C3N. And they make this argument that data really fundamentally are a communicative process. That if we begin to shift our focus from the kinds of daily data as giving us better and more information, and rather as data giving us the possibility to connect to our patients and to create new ways to collaborate with our patients, then we might have a different kind of model about what personal self-directed tracking would look like. So this notion matters because the context in which the data are collected are contexts of people's lives in which they are the experts. So just as Hugo Campos wanted to be able to look back at his own data and say, on Tuesday, I was in a stressful meeting, he understands points and contexts about things in his own self-tracking that no scientist would be able to understand, right? That he's got that knowledge. And so once we begin to think about this notion that the context for people's data is as important for that interpretation and sense-making in their own lives, and as important in their own choices and actions, and deciding what choices and actions to do in terms of that data, then we open up new kinds of possibilities for engagement. So, what should we do? Based on this study that we did on personal self-directed self-tracking, I've got a call to action for digital health and the ways we need to be really conscious of the kinds of data we marshal to speak for people. So first, what we see time and again, and what we've learned from the quantified self community and from the Cincinnati Children's Hospital study, is that healthcare providers and patients really need to be involved and at the table when thinking about kinds of data that can be used for health. It's wonderful to begin to think about how trace data, say from social media, might give us insights to populations. But when we're bringing data into having conversations that influence clinical decision-making, we need to be sure that we're capturing that individual context within the moment, within the data that is telling us. Second, these consumer-grade devices are opening up phenomenal possibilities for new kinds of data that can really help people manage their conditions better, make discoveries about themselves, choose to lead healthier lives. But the devices must absolutely build privacy and security into the very hardware elements of those devices. When such data can lead to inferences about our health, I would argue passionately that we need to protect those data like we do health data. So if certain kinds of keystroke patterns may be reflecting that one is about to have a manic episode, say, this is actually, some of you may know this study, we need to make sure that people's rights to privacy of their health data are protected in those environments. Third, we know that there are existing inequalities in health that technology has not yet been able to help us solve. We have persistent inequalities. When Dr. Lopez showed the map of the United States, you might have been able to tell I'm American. When Dr. Lopez showed the map of the United States, I saw my home county lit up in red, right? We know what is the social determinants of health in poor areas are not questions that are going to be solved simply by adding and throwing social media data and smartphones at the problem. It's not an AI problem. It's not an information problem, right? It's not data, it's resources. But what we don't know yet is how these data and how the existing inequalities will change and shape the models that we use for going forward. So if we build models for the state of health based on social media data, are we accounting for the inequalities of who does and doesn't participate in social media? Are we accounting for the inequalities that are already driving the differences in our data? And are we building models that appear to be objective when really they're built on biased data? So I'm not saying we can eliminate that bias, but we actually need to be very careful in how we think about where bias gets amplified through the appearance of a seemingly objective technological AI models. Fourth, and perhaps most important to the people that I studied in self-tracking, access and control over data and data about ourselves and data about our health is fundamental, and that access and control should be regardless of the genesis of the data. So if data about me from my smart devices is telling me something about my health, I should have the same rights to control and access to that, and controlling who sees that and what they can do with that data, if that data is saying and inferring something about my health status. And finally, we're not going to have digital health that encourages patient behaviors, healthy behaviors, unless we can assure freedom from the potential harms of these data. So when fitness trackers and activity trackers are subpoenaed to be used in criminal cases against the people who used them for health reasons, when we see subpoenas to, say, smart home speakers that allow for very intimate details of people's lives to be used against them, we're seeing a kind of self-incrimination by our data. And we're seeing a self-incrimination that many people feel quite rightly threatened by. But it also cuts the possibilities that we have for extending the enormous potential for creating positive outcomes through encouraging healthier behaviors through this kind of self-tracking. And with that, I thank you for your attention, and I'm looking forward to your questions.
Thank you, Gina. Yeah, so we have 5 to 10 minutes for questions. There are 3 mics in the room, and yeah, please keep your questions concise, and please in the middle.
Okay. Hi, my name is Cameron. I'm an undergraduate student in Health and Society, and my question is, how far away are we from getting like a world digital data policy? Like we have the World Health Organization, we have the World Bank, and they're respected in most areas, but like a perfect example is that every other Tuesday, Doodle and Facebook get fined in the UK, but those fines don't happen in North America.
Yeah, so what's going to happen with bringing world digital policies in kind of alignment? I will say and I'm not the policy expert. We have other policy experts in the room, but I will say there's a couple of ways to go about thinking that. One is there is a de facto health privacy standard now that is global that's called HIPAA, based on a US law, was not designed to be a health information global standard, and yet because there is a clear checklist to make something HIPAA compliant, we see HIPAA used as a security standard in cases where data are not necessarily being collected about US citizens in their clinical care conditions. So we can see the repurposing of some of these standards, and I think we're going to start to see more of that. So I actually think we're going to, that GDPR, the General Data Protection regulation that came out in the EU, I actually think GDPR is going to change some of the terms of the debates there. So on the one hand, you'll see jurisdictions that push for certain kinds of data protection that have spillover effects. Now, what does this mean if one is, say, a small country? And even within the EU, some of the small countries are starting to have some of these conversations, right? So some of the questions around languages and access to language. For example, Iceland is pushing on some of these. So is Silicon Valley going to shift their policy because Iceland puts in a particular regulation? Maybe not, but if larger trading blocks can kind of band together, I think we can see some of those actions.
Yeah, Bill.
This might not be a fair question to throw at you without warning, but what's, just reading the newspapers, what's the deal with Huawei, the Chinese telecom company, and is it dangerous? And just in relation to your talk, and you may say, I don't know, and then another question can follow. But.
No, I'm gonna do that thing where I pivot ever so slightly, and I say, oh, Huawei, and then let's talk about China. So let's talk about China. What I'd like to do, rather than talk about device security and insecurity, which is partly what's behind your question, right? So as you may know, this is a smartphone maker whose phones are not legal to be sold in the United States or Canada. Is that true? Yeah, you can buy them in Canada. Can't buy them in the US, but you can buy them in the UK. And that is in part because of concerns around base level security. I think the question to ask is first, if we're developing these large cultural, political blocks of policies around information technologies, say a Silicon Valley block that North America and Europe have bought into. We also see a block that is China. And that when we're working with thinking about the future of the internet, we may actually be thinking about multiple internets, and we may be thinking about multiple types of ways that these data are used and marshaled. So I think we need to hold up the best of the values that around privacy, protection, around innovation, around preserving democracy that we see built into some of the kinds of conversations we have about a Silicon Valley way of thinking. And that's as important for thinking about global public health through digital health as some of the other kinds of phenomenon. So when these tools and devices are used to surveil and control their population, it's going to be hard to use them as objective healthcare measures in trusted, honest, secure ways without naming any particular company that may or may not be violating that.
Thank you. In the middle here.
Thank you so much. Very inspiring, and I think you ticked off pretty much all of the concerns that I feel as I look forward. My name's Ann Toohey. I'm with the Brenda Strafford Center on Aging. And I'll quickly recount, I have an acquaintance in a different province. Some of what you've raised is already upon us. I watched her shaking her smartphone up and down because her insurance policy rewards people who maintain 10,000 steps for multiple amounts of days. So, and this is a fairly active person, but so some of these potential harms are already here. I guess that's part of a comment and a question because, you know, there's a lot of interest in the gerontology, geriatrics around increased monitoring as people age, and I guess fitting into kind of the sociological paradigm. What are your thoughts around continuous monitoring and the options to opt out?
So I have a doctoral student in Singapore right now, and talk about, there's one way to talk about Singapore as an authoritarian regime. There's another way. Singapore is really selling itself as smart city, smart nation, right? They're trying to build the smartest population in the world. They are in their public housing, which most people in Singapore live in. They are building now all new tower, HPD tower blocks actually have integrated smart home sensors, and that they're continuing to think about how you do continuous monitoring for the elderly. So one of the surprising, she's literally just back from her first field work, so this is brand kind of new insight. One of the things that she was shocked to find is that you have this great emerging data about elderly people in their homes, and how is it being used? It's actually being used as an in-out board for the caseworkers so that they see when their clients are in their home. That's the only way the data are being used now. So we're gathering more data than we can actually bring sense and sense-making to. And I think we need to be very careful because the kind of imaginaries that people have about how they're gathering data can do real harm. So another case from geriatrics is a study in Seattle that was looking at aging in place and sensing, found that the elderly participants one elderly participant was refusing to take a shower because he thought that there were sensors in his bathroom and that were monitoring him. So even though he had gone through informed consent, even though he was a participant in a university scientific research project, even he didn't fully understand. So we have to do more education, and we have to address fully these practices of everyday life in how people understand this data around them. And we need to fight for the kinds of rights to privacy protection, access, and control that will really give people the autonomy to shape their futures in these digital health environments.
Okay, I think we have a couple more minutes, 2 or so. Yes, over here, please.
Thank you for an excellent presentation. Very much enjoyed your presentation yesterday also, actually. Your comment on self-incrimination with the data that I'm generating got me thinking, if I would still be protected under the Fifth Amendment rights that I have?
That's a great question. I don't know. But yes, right now that these data are being used by law enforcement to help help figure out whether someone has committed a crime and whether they can be implicated in being at a certain place at a certain time. So I think we do need to be, from a society point of view, we need to actually think about if that's the kind of future that we want, and especially if we want to encourage the use of such devices to help people direct their own lives to lead healthier behaviors. We're not going to be able to do both of those paths. I think final
Sure,
question.
we only have 1 minute. Yep.
Thank you. It's an excellent talk.
Thank you.
So my name is Vineet, and I'm with the Alberta Health Services and University of Calgary. I'm a scientist. So, you briefly alluded to that data is not equal to action. So in light of AI and big data hypes that we are witnessing, I want to know your thoughts about non-action on social determinants of health. Is it the lack of data, or is it the lack of willingness at the appropriate levels to do some meaningful action? And then my sub-part of that question is, in your experience or opinion, do you think that AI has the capability or capacity to perpetuate inequity in the society?
The short answer to that last question is yes. The answer to your first question, I think, is best summed up by a wonderful psychiatrist who was with me at the Medicine X conference at Stanford several years ago. This is a story from the book. She stands up in the middle of a talk from one of these activity device makers, exercise device makers, and he says, data equals knowledge, and knowledge equals change. And she was like, excuse me, I'm a psychiatrist, and I'd be out of business if that were true. And so I think I pushed this back to a room full of people interested in improving health and healthcare outcomes. We know that these growing epidemics are not necessarily ones that are, that these biggest causes of death globally are not necessarily ones that we need better data on. We know that individual action can lead to change, and that's actually, I think, where we have to do our work. We have to think about how do we motivate people to lead healthier lives, and we're not going to do it in a world in which we assume that if they strap a device on their wrist, that they'll suddenly get healthier. And with that, I'm out of time. Thank you.
Thank you, everyone. Thank you, Gina.
Hello, my name is Brenda Hemmelgarn, Department of Community Health Sciences, and I'm very pleased to be moderating this next section of rapid fire talks. We've had some amazing presentations already, and now we're going to give you some of our local context and more of the clinical applications of big data in health and healthcare. So very excited to have our first presenter, and that's Dr. Maria Santana from the Department of Pediatrics and Community Health Sciences, and she's going to talk about including what matters to patients into big data for health. Maria.
Thank you, Brenda. Great being here with you. I have to hurry up because I've got very short time to tell you a lot of things. So why do we want to include what matters to patients into the big data for healthcare? Okay, so you will agree with me that that healthcare systems really aim to address what, to alleviate symptoms, improve quality of care, and the quality of life that they, to the patients. Let me move this. I think I moved too fast, sorry. And this information, all the information in terms of symptoms, the burden of the side effect from treatments, the quality of life and the quality of care, this is all information that comes directly from all of us, from the people. And so how do we capture these patient reports? And so the big concept of the big data for our Kamen School of Medicine considers the patient's report as part of the data sources. But what kind of patient reports am I talking about? So the reports have different shapes and shades, and I'm going to be talking more about the patient-reported measures. What are standardized methods to capture quantitative data from the patient's health and quality of life? So what are patient-reported measures? And so there, under this umbrella term, there are two big group, I would say. One is the patient-reported outcome measures and the patient-reported experience measures. And while the patient-reported outcome measures assess the symptom burden, the diseases burden, the treatment burden, the quality of life of the patient, the patient-reported experience measure assess the quality of care. So did you receive timely care? Did the providers communicated with you in a way that was meaningful and it helps managing your condition? So how do we do this? How do we include this measurement into healthcare? How can this happen? And in an effort to explain that to you today, I developed this figure, I guess, yeah, where I'm trying to explain a very complicated thing in very little time. And basically, it's like killing 3 birds. Is that thing working? Yeah, 3 birds, 1, 2, and 3 birds with 1 stone. So basically, what I'm going to try to explain the complexity of this is we can collect these measures with electronic devices for clinical care use. But then when we put them in the big data and link it to electronic medical records, admin data, we can then use it for quality improvement and also for patient-oriented research. Basically, what it does, some of the big effects, and I'm talking from the evidence from many studies, is that it really allows decision makers to look at resource allocations, allows for to measure performance in healthcare, and really from the patient-oriented research piece, it really allows to involve some of the patient voices in the research that we conduct. I am going to focus on the clinical care aspect and how this is potentially done. So what I'm going to explain now is, when we use it in clinical care, really, the purpose of using these measures in clinical care is to support the decision making, is to co-create health, is to support and add to the delivery of care so that the healthcare providers have that extra additional data. But it has turned out that when we measure that addition, it's not that burdensome for them. So that's what they're telling us. So how it happens? Okay, not moving now. Yeah. Okay. So this is an example of how it can be done. So in many different countries around the world they've been collected on regular basis, and they've been included into the big data, and they're collected before the clinical encounter using electronic collations, so electronic devices, and then the results are graphically represented and shared with the healthcare providers at the time of clinical encounter. And what the effect is almost like a cascade effect. So there is an improvement in communication. There is that new piece of information that is more about perhaps the level of pain that is not related to your heart condition, but it's the pain that you have at the back. But it brings all the pieces of the patient. And so instead of focusing on the disease or diseases, you focus on the patient as a whole. And so improvement in communication that leads to engagement and decision-making, shared decision-making, that co-creation of the care planning that improves experiences, and not only the experiences from the patient or the caregiver, but also the experiences from the healthcare provider. The healthcare provider feels good about it. And all of this leads to an improvement in outcomes. And the outcomes, the recent research done by Ethan Bash in oncology shows that there is improvement in survival. And I think that that's compelling outcome. And so it really will be a real pity that we do not collect these measures toward person-centered care and personalized medicine. Thank you.
Very much, Maria. We have time for a few questions. We have 3 of the mics around the room. If you could please introduce yourself prior to asking your question. I just have one question, Maria. I wonder if you could give us an example of how we could incorporate these PROMs and PRAMs with the other big data measures and how you think that they could be used, or has that already been done in some clinical context?
Yeah, we've been doing that. Yeah, thank you for the question. So for example, and I'll give you an example from the PROMs and something that we did at the University of Alberta in Edmonton with the lung transplant patients. And so when we put it together so we aggregated the data, and we look at the level of pain and stratify by underlying conditions. So we had then we gain an understanding of the level of pain for patients that had COPD or cystic fibrosis or any other of the underlying conditions, and it was very useful for the team to realize that they were standardizing the care across all underlying conditions and providing the same type of treatment, but the patients that had COPD, so chronic obstructive COPD, pulmonary disease, they had a higher level of pain, and they didn't know that. And that knowledge came from aggregating and looking at the data and then stratifying by the conditions. In the sense of patient experiences measures, so one of my students, my PhD student, Kyle Kemp, and I have been working with Alberta Health Services patient experience data for children and for adults population, and we have been linking it to EMR and admin data. And really, we are really understanding who are the patients that have a better experience, who are the ones that have a worse experience, and what are the pieces. Yeah, thank you.
Ariel Ducey from Sociology, thank you very much. In your experience, are there aspects of the clinical situation or of patient experience that don't get taken up in these measures very effectively?
Yes, we always miss pieces, right? And because it's very, so we're trying to do an individualistic approach, but then aggregating the whole thing. So the way we are looking at that is we are adding blank boxes so people can type, and the next thing will be recording the voice. Yeah, and then using artificial intelligence tools to understand what it is. So data mining and stuff like that. Yeah, thanks.
That's great. Thank you very much, Maria. So our next speaker is Dr. Matthew James. He's an associate professor in the departments of medicine and community health sciences, and a great colleague of mine, I might add. And he's going to give us an example of using big data to maximize value in healthcare.
Thank you very much, Brenda. What I'd like to do in the next 5 to 10 minutes is try to give you a snapshot of some of the challenges and opportunities of delivering insights from data into clinical care, and provide 2 examples in the area I work in kidney disease, of strategies that try to do this to illustrate these concepts. And I'm going to start with this relatively simple formula that tries to describe the complex thing that is value in healthcare. But here, value really describes trying to maximize patient experiences, maximize patient outcomes, and do that with the most responsible use of resources and use of money. But despite our goals to deliver valuable, efficient, appropriate care, there's many examples in medicine where actually care is not delivered in the most valuable way. And actually, people who are at higher risk of problems, higher risk of poor health outcomes and experiences, actually are not cared in the same way as patients with lower risks. And this is some data from the Alberta Provincial Program for Outcome Assessment in Coronary Heart Disease in Alberta, looking at heart procedures across 3 groups in bars. And these light bars here show a risk score, a way of predicting poor outcomes in patients. And you can see that across these 3 groups, there's an increase in risk of poor outcomes when we look at patients receiving these heart procedures. But what actually happens in this example is the treatments that are received actually go down in a paradoxical way with risk. So sometimes the way we manage and care for patients actually doesn't align with their risks. Data through modeling provides us with opportunities to create models for risk that might help us better align treatment to risk. And there's many examples of this in medicine where we try to create models to identify patients at higher risk. And we can use these to report outcomes of patients by different risk status. We can publish them. We can use them to feed back to stakeholders. However, despite a plethora of models, very few of them actually penetrate into clinical care and ever develop the evidence base to show that they improve care and outcomes. And this really, I think, requires a change in the way we use predictive models in healthcare. What we want to do, ideally, is bring the knowledge that models could provide and augment that into the information for patients and care providers to make decisions, and be able to apply that to an individual to benefit from knowledge in the past for a patient under care today. But this really requires disruption in the healthcare system and novel strategies and solutions to be able to deliver this into the healthcare arena. And this is a slide from a collaborator, John Spurtis, in the United States, that I think shows this model very nicely of the idea that models provide us with an ability to take complex calculations that inherently humans are not designed to do, but to bring the information in terms of prognosis into care at that moment and place when we interact with our patients and apply those insights into care. And here you can see a complex model being delivered through a tablet to a physician interacting with a patient that's taking a large potential variable group of patients with many different outcomes and sorting them into different risk profiles that might actually be managed in different ways depending on those risks. So I wanted to move to a couple examples in Alberta that are trying to apply this. And the first is in the setting of heart procedures, angiograms and angioplasties to treat ischemic heart disease. And the most common serious injury or complication of these is kidney injury. And some costs are shown in the table here, and the rates in Alberta are shown over on the right side. Ideally, we would like to do these procedures as safe as possible and do them with the lowest incidence of damage to the kidneys. And the risk of kidney injury can actually be predicted. So this study is actually implementing a risk score and a number of other elements into care in Alberta to reduce the risk of kidney injury. It does this through leveraging an electronic platform across the province that captures detailed clinical information. And when that information enters the system, a risk score for kidney injury is calculated using data from across the province. Out of the many risk scores that are available, the approach team has been able to identify that performs the best in our Alberta patients and calibrate that to our population. And then provide specific information within that system to healthcare providers, the cardiologists who provide this procedure, to make them aware of patients at risk and specific tailored interventions that they can do to lower kidney risk. And this is being implemented at the level of clusters of physicians and evaluated across Alberta. The second example, before I go to the second example, the one last part of this I think that speaks to big data is then finally feeding that back to physicians through audit and feedback of their processes and outcomes. The second example is looking at the transition of patients who develop kidney injuries into their long-term health consequences of chronic disease. And this figure here shows the challenge that when a patient develops a kidney injury in hospital, there are many potential outcomes, changes in their kidney health that could subsequently occur. And we may not know at the time when patients go home who will have chronic kidney diseases. So working with the Interdisciplinary Chronic Disease Collaboration and the Alberta Kidney Disease Network in Alberta and collaborating with colleagues in Ontario, prediction models were developed to identify patients with these problems. And 6 commonly measured variables that are accessible in clinical care could actually perform reasonably well for identifying patients with long-term health consequences. These models could be validated in other areas. They could be used to develop risk thresholds where doctors agreed they would manage their patients and follow them up differently. And this is now being tested in 4 hospitals across Alberta to guide how patients would be followed up after their kidney disease in hospital. So I'm going to end coming back to this formula around value in healthcare, and just end by saying that I think with the increasing availability of computerized data sources penetrating clinical care in Alberta and across the world, there's more and more opportunity to deliver insights from data into clinical care every day. But it really does require disruption in the healthcare system, engagement with stakeholders, and evaluation to ensure that these interventions have the desired benefits. And I'll end there and thank many groups, individuals, and organizations that support this work. Thank you.
Thank you very much, Matthew. Open to any questions that we may have. You alluded to this a bit. You spoke about the disruption. I wonder if you could speak to that a bit more in terms of the actual clinical application. So utilizing these decision support tools within clinical care. So using the big data that we're all working with.
Yeah. I mean, the first project's very interesting because it takes advantage of the fact that disruption happened many, many years ago when an electronic system was introduced into the cardiac catheterization labs across Alberta. And so in some elements, the disruption may not have been as great as when those tools first came into use. But it certainly requires a lot of work with the stakeholders and the physicians who are using them. This project with the approach team spends a lot of time engaging with physicians and staff in those units to implement these, and and we've also seen it takes time to build up those processes and get them running efficiently. So there's certainly an important component, I think, of working with the stakeholders to implement these changes.
Do you think that will be a deterrent to the use of big data in healthcare?
I think that there is. With all of these electronic medical records, there's a lot of discussion around the way it changes the practices we do. I mean, one of the greatest frustrations has been taking away some interactions with patients and perhaps directing time over to computer screens and how that influences our interactions. So, I see the conflict, the pulling in both directions. What I hope we'll be able to see is that these meaningful uses we can really maximize so that those advantages are brought out from these systems, and we don't suffer the other pieces that change our work.
And just a quick add-on question that's actually even a hybrid to Maria's presentation is how can we get information in these models and decision support tools in front of doctors and nurses and patients, and what are the barriers to getting such tools and platforms into care?
Yeah. I mean, there are multiple barriers. I think that many system barriers exist. I think the technology barrier, I think now is going away, especially in Alberta. The systems are coming. They're being implemented more and more widely. I think when there are opportunities where these systems exist, we have an incredible opportunity to leverage that and get the insights from the data and the models into care. So hopefully now with the arrival of these tools, we can, in the next few years, we can really move towards leveraging them for these types of functions.
Thank you very much, Matt.
Thanks.
So now we're going to move on to our third speaker in this series, and that's Dr. Marina Gavrilova. She's a professor in the Department of Computer Sciences here at the university, and her talk is going to be about machine learning and biometrics for medical applications.
It's my pleasure to speak to such a diverse and engaged audience and broad audience today. So I'm head of the Biometric Technologies Lab in the Department of Computer Science, Faculty of Sciences, and also associate head research and planning for the past 2 years. I have a history of collaboration going back 15 years with Faculty of Medicine, with Liberty Health Care, Foothills Hospital, O'Brien's Institute, as well as currently City of Calgary and Drop-In Center on the variety of health issues ranging from cardiac data monitoring to RFID implementation in the hospital environment to observing the patient's mobility and providing treatment for the postural imbalances that I'm going to quickly talk about today. But I actually want to take first 2 minutes to mention or to draw you to the global picture that emerges from this symposium. So I think Gina, in her excellent presentation, nailed the problem on the head. More data is being generated and produced right now than we can make sense of, analyze, or implement and use it in practical application in treating patients and providing higher quality care. We also have issues with ethical use of this data, legal implications of using some of this data, such as who can access it, who has ownership of the data produced by the patients, as well as the proper procedures to store this data and ensure privacy of this particular data. So we have tons of problems in front of us. I see lots of young faces in the room. Can I just do a super quick experiment as well and ask everybody who is a graduate student or research associate, assistant, or trainee to raise their hands? See, this is the new generation. This is up to you guys to solve those problems that we're facing right now. We're just here to bring you those problems, and you'll have to be solving them. Anyway, so I'm going to get back and point another issues that emerged in the past few years. So right now, we actually have technological tools that's been developed that are more powerful than ever to address those problems. Example is a few years back, it would take my PhD student 5 years to develop a machine learning algorithm, supervised machine learning algorithm, to understand certain patterns in the biometric identification of the human by the facial recognition. Right now, I have a new student who is coming in, and he can, crowd this code using deep machine learning in 2 months and get results that are 99% accurate. So we have amazing tools that emerged over the last few years to solve these problems. Other example, as you know, AI right now, artificial intelligence, there was a first example where it had a position and the board of directors in one of the UK company, along with other humans, making decisions about strategic directions of multi-billion-dollar businesses. And we also have an example where machine learning not only succeeded in creating, as you know, the best chess playing program that beats humans 10 years ago, but recently creating the software machine learning based that can solve and play Go, much more complicated game, it was mentioned yesterday as well, in a much effective way, and also can teach another software these algorithms of how to learn this game, and so the second software that learns from it can beat the first software. So this is absolutely amazing in terms of possibilities that we face in front of us. Now I'm gonna come back and bring it to the slide. So, okay, I have to go the other way. There we go. Just flip. I mentioned a number of applications where we see our research fit in the Department of Computer Science Biometric Technologies lab in person recognition, collaborative social environment, situation awareness, personalized medical devices, personalized medicine, as well as physio rehabilitation and fall prevention. And there's a number of devices that incorporate smart technologies, as those that I mentioned before already on the market. So we see a very nice fit between the biometric technologies and medical applications as well. And as you know, biometric technologies started at the Sir Francis Galton studies of the anthropologist on looking at observation of the body measurements, height, weight, fingerprints, and progressed right now to things such as brain waves, the temperature of the body. The blood pressure can be used as one of the biometrics. The DNA can be used one of the biometrics in mind. This is where we do research in our lab. These are examples of some of the data that we can sense about the person, so the way how we walk, the way how we speak, the way how we sign documents, also keystroke, mouse, dynamic gesture. And I have also one of my former students in the room who did a PhD research on using our online tweeting habits and our social network as a way to understand information about our patterns, about potential risks, our interests, and essentially about who we are. And now she's going to actually apply this data and work in the Cummings School of Medicine as a postdoc. This is essentially those emerging research areas that I mentioned before. I'm going to skip this slide because I brought this into perspective in the beginning of my presentation. Example of one very small particular application is how we look at the way how humans walk. We can understand and identify person behavior and perform analytics, whether it's healthy or not healthy person based on the way we walk. We can also do activity recognition. Much more interesting question that we asked recently, and one of my master students working on it is, can you understand emotional state of the person, or whether a person in distress from just how he sits, from its posture? There are lots of cues that can be telling about that, and we're trying to solve this problem as well. It's obviously not related just computer science, psychological studies and medical studies also will help in this domain. And then the recent application, the project that we're doing right now, is a project done together with Physio4D, it's a local Calgary startup, and the Vital Posture Clinic that performs chiropractor services and tries to help patients with pains and different postural imbalances or recovery from the injuries. And essentially in this project, to make the long story short, we created visualization for them of the patient posture that doctors actually found useful for them, to look at the mismatch in the proper posture from improper posture, to also track the patient progress over time. We implemented our proprietary noise reduction technique on those postures in order to get a cleaner data and better data that we can use it in our machine learning application to learn. We created proprietary machine learning methodology based on deep learning. So it's developed fully in the lab. It's actually improvement over the standard, cookie cutter methods to do machine learning. So we have number of perceptrons. We have our own way to deal with model overfitting. And my student has a poster right there. He can talk more about that. And at the end, we developed a fully functional system to perform classification of simple, average, and complex cases. Now, the experimental result that you see right here on just 29 patients, we getting on average 99% accuracy of this classification. Now, I want to bring attention to that. So that was done within 2 months of work, using very, very powerful deep learning mechanism. And it's based, where do the raw data comes from? Where is the ground truth? It comes from 30 years of research of the expert working in the clinic, doctors that saw all these patients, they perform this classification. So essentially what we're doing is we're taking all this knowledge, feeding it to the algorithm, and saying that, can you replicate behavior of this expert in its domain? And we can see that it's possible, but we don't know why it's true, and we don't know how the insights of this machine learning work. So that perhaps will be one of the more of the problems that next generation will be solving later on. And with that, I finish.
Thank you very much, Marina. Are there any questions for Marina?
Yeah.
Huda.
Maybe you have no time to talk about third one as automatically predicting assessment case.
Mm-hmm.
Can you talk a little more this? It's really interesting to see how accurate it is.
That's right. So essentially we have a raw data. Yeah, it's a research. That's exactly this case study that I was mentioning about. So we have a raw data of the patients where the labels has been given when they come to the clinic with different symptoms, varieties, pain, discomfort, cannot sleep. And the doctor the doctor's team, based on obtaining data using Kinect sensors as well as looking at their own chart and having their own questionnaire, will determine where the patient is a simple, average, or complex case, and then we'll decide the treatment based on this. And when we had, through the series of meetings, right, with those practitioners, when they gave us the data, they say, can you have an automated software that without our expertise can make the same diagnosis. And we said, well, let's try. We had no idea what's going to happen, and we get a 99% accuracy on the given data set, cross-validated on automatic prediction of it. Now, we want to see what happens when the data set of the patient becomes larger. We want to see when they're presenting with maybe a little bit different symptoms. We want to also incorporate some of the other factors in our decision-making, such as age and gender, right, and the previous history, so that this is just the very first results. I hope I did answer. Thank you. I think I'm out.
Thank you very much. And now someone who really needs no introduction at all, our very own Dr. Bill Galley, Scientific Director for the O'Brien Institute, and I love his title. It's a sneak peek at ICD-11.
All right, thanks, Brenda. I'm up here because we're showcasing the youth of the University of Calgary. And actually, I'm up here because I was tricked by Huda Kwan. We are both involved in the WHO Collaborating Center that we have in health information and disease classifications. And one of the big areas we've been working in is ICD-11 development, as well as other disease classifications and health information systems at the WHO. And there's a big change coming because ICD-11 was released in a preliminary form to the world in June of this year, and then it goes to the World Health Assembly in May of 2019, after which countries will begin to use it. And each time, and it's really once a generation, each time there's a changeover in ICD, it is a Y2K transformation for teams like the Global Burden of Disease group, because they need to learn a new classification system and disease definitions. The international classification is in its 11th revision. It was originally developed as a list of causes of death in 1854 by William Farr. And it is in this system that we talk about ontologies of disease. And ontology was a new concept to me when I got involved in this. And Cello's smiling in the audience because I refer to every mention of ontology as like dropping an O-bomb. And you impress the audience, you confuse the audience. But ontologies are concepts from philosophy that are applied in computer science. And it's where notions of disease are based. Is gaming disorder a disease? Well, in ICD-11 it now is. It is controversial. Is congenital Lyme disease something that even exists? Is chronic fatigue syndrome actually a disease or a condition? And so when you see Alan's impressive information on global burden of disease, each of those concepts are disease concepts that are defined in the International Classification of Disease. And what is a disease is actually a 50-minute talk, not a 5-minute talk. I'm complaining to the organizers after I finish. So just very quickly, because this is only a sneak peek, ICD-11 is very different. Many of the recent versions of ICD were really just lists of individual codes that are used to code a single condition, and the codes can't be combined and they're fairly static. ICD-11 has clustering features, so diagnoses can be strung together. There are extension codes that allow for characterization of anatomical details, severity, a number of other features. There are sophisticated IT tools that support application of ICD-11. There are enhanced coding rules that are clearer, and there's a goal that these will be harmonized in the application internationally, better cooperation among countries to deploy ICD-11 in a uniform way rather than a fragmented way as occurred in 10. There are mapping algorithms to ICD-10, so retroactive mapping, and in terms of cutting-edge work, prospective mapping to the standardized nomenclature of medicine, or SNOMED, which is a terminology which is more granular than ICD, that forms a Rosetta Stone connection to free text EMR, so there's potential for mapping and natural language processing. There's a chapter on functioning and disability. There's enhanced clinical detail. And there's now a section on traditional medicines. The ICD-11 is interoperable and connects to a number of specialized versions and classifications. So what is a medication? Is a particular homeopathic remedy actually a true entity? Well, there are classifications of substances, there are classifications of procedures. The International Classification of Health Interventions. Is acupuncture a procedure? Well, absolutely it is. There's many different types. So every intervention, disease, drug, symptom, any health concept is defined in ICD. This is a conceptual figure. Sheila Carpendale's team has laughed at this slide, saying it's cute, it's rudimentary. I'm not a professional InfoViz person, but the notion here is that we try to capture health detail, and it's nebulous. And sometimes people write things down in describing a patient. So there's free text data that's more granular, and it's a distillation of the true detail describing a health phenomenon. And then this can be captured in terminologies such as SNOMED, and then SNOMED can be mapped to ICD, and then ICD can be combined into indicator definitions, and many of you will know about the Charlson Comorbidity Index or surveillance definitions of diabetes and hypertension, and these are in aggregated units that then teams like the Global Burden of Disease will then report on prevalence of diabetes, and that's this distillation that happens. Just as I finish, I'm just going to give you a granular example of the clustering, because I think this is the most notable new feature in ICD-11. It is essential to the quality and safety use case that I've been very actively involved in. Clustering did exist in ICD-10, but it was not ubiquitous, whereas it is here. Codes can be coded individually, but they can also be combined. And extension codes, which are qualifiers of so-called STEM codes, can be connected to codes, and you can see expressions of codes like these. And ICD-11 codes are like individual words. And now in ICD-11, you can write clinical sentences through this clustering. And to give you this example, a simple example, a patient presents with bradycardia, so slow heart rate, due to battery failure in his pacemaker. There is a code for the actual harm in this circumstance, bradycardia. There's also a code for the cause of harm, which is a cardiovascular device associated with an adverse incident. So that's a code. And then the motor mechanism of that harm is battery failure, for which there's a code. And then in the clustering, it looks like this. So you get a string of codes. And then if this was something that happened in the hospital, you could have a timing code, which is an extension code that's presented. So an ICD-11 concept, any of you have looked at ICD-10, that's not what 10 looks like. It's drastically different, and it's a language. So that's a sneak peek. And then the visual, and then some of the IT tools that allow you to select codes. You can see some of these at the WHO website if you just Google ICD-11 platform. And there's videos, training guides, a reference guide, an index. So it's not a static paper-based index. It's actually a digital index that maps to disease. Thank you.
Any questions from the audience? Cello?
Thanks very much, Bill. I foresee a bit of a nightmare if the residents start using these on the phone with us at night. MD 91.2 followed by PG 81.2. It's going to be pretty tough to follow. The question is about intellectual property. So you and Huda, you are world leaders in this area. These are going to be used in hospitals all over the world. Maybe not for you personally, but for the university or something like that. How? Just give me an example of your thoughts about how this could be commercialized or otherwise turned into intellectual property that would benefit the health system.
Yeah. So I'd almost defer to Alan, who spent many years at the WHO. So the WHO certainly has a mandate to advance health on a global scale, and they do so in recognition of the information paradox, which is that regions of the world that have the greatest burden of disease have the least health information. And in a social justice paradigm, the WHO is seeking to really democratize health information tools and platforms. So the WHO really has a social agenda that's about delivering delivering tools without a profit motive and is partnering with the private sector, where private sector entities become a propagator of the WHO agenda, because in the background there's a need for a lot of automated coding tools. There will be great potential for NLP or machine learning algorithms for automated coding, so that somebody could dictate a paragraph about health and automatically have that string of codes pop up without there being a need for a human being. So there's a real potential for private sector to work with the WHO in its public sector social justice goals of dealing with the information paradox through better information. So good question.
And we've got time for 2 quick questions, one over here.
So the ICD-10 is a very complex collection of these different codes, and we were talking earlier about big data, and for clinicians, it's trying to get to like what's really important here. And some of these codes that I've seen are quite interesting, like walked into a cow, spacecraft collision injuring an occupant. These are all actual codes. So is there progress to kind of like make it a little less clouted?
Yeah. One of the best codes is there's a funny book called Struck by Orca that my colleague and friend Dean Jurgens gave me as a gift once, and it's an illustration of funny concepts, and one of them is sucked into jet engine, subsequent encounter. So the poor schmuck did it twice, survived, and then it happened a second time. So that's pretty bad. Those funny concepts and absurd concepts are the product of the ability to bring together multiple concepts. So cause of injury, the actual harm, whether it was initial encounter, the context. And in ICD-11, the injury group that's led by James Harrison, who's a tremendous colleague from Adelaide, Australia, they've tidied up the logic of that section, so the mix and match is a little bit less crazy, but there's also a real flexibility to describe a whole bunch of scenarios. So.
And one last question.
And I'll be quick too, so go ahead.
Hi, Stephen Dykstra from PhD student at the Stevenson Cardiac Imaging Center, and as someone who works with ICD-10 codes, ICD-11 looks a lot better, so thanks for the sneak peek. But one of the problems that I've found searching codes myself and talking to others is with a complex system where you can do all these combination codes, do people actually use it, and is there training in place to teach people to use it in a better way? Because most of the codes you find are unspecified, or they don't actually use the complexity you've added to the system.
Yeah, so great questions, and there's a huge amount of effort. So we know this is way, way, way better. But to have good information, it also has to be, the training tools need to be developed, and then the testing, this needs to be brought to the masses to work. And so we have a big group of people, actually Kathy Eastwood in the room, she can wave or make noise over here in the middle. Kathy's leading initiatives in training materials, and I should mention just as a quick infomercial that we are hosting here in Banff in October, the WHO Family of Classifications Network meeting, which is a very significant international meeting. So our collaborating center will be hosting the world. And Health Canada has a big agenda, and CIHI here in Canada, of socializing ICD-11 for the policy shift of moving in 2023 or 2024 to Canadian implementation of ICD-11 with good training materials and really a pathway to better data, because you need good ontologies and good concept definitions for good data, and this will feed into the global burden of disease. The implications are far-reaching. So, thank you.